Can we zoom in a little bit? Because I know people have always said they have a hard time seeing anything going on up here. Okay. Good morning, everybody. This is the July 26th State Anatomical Advisory Committee. We'd like to call to order. First, we need to establish and certify a quorum. So I will go down a list of advisory members. Miss Bethany Wright. And if you're here, I need to see your video and your face, please. And please stay here. I know Miss Wright just texted me a few minutes ago saying she's not going to be here because she has duties this morning in her skills lab. So she has an excused absence. Mr. Cody Leposki. I know he sent an email in saying he would not be here early this morning. He's got some duties too, so he has an excused absence. Dr. John Hubbard. Dr. Hubbard, are you on there anywhere?
But he's now dropped off.
I know he's on here earlier. He has classes too this morning and has an excused absence, but he said he tried to jump back on. Dr. Carrie Gilbert.
I'm here.
Thank you, Dr. Gilbert. Mrs. Julie Long, right here to the right. And we welcome her as one of our new committee members. Mary Mena.
Here.
Fantastic. Myself, Aaron Ali. So we have a quorum with 4 of us minimum. And we will get.
We need to vote to approve the absence of, to excuse.
Okay. So we need to vote to approve the excused absences of the people that were on the committee that I said are excused for this morning, which would be Ms. Bethany Wright, Dr. Hubbard, and Cody Leposki. I'd like to have a motion to excuse their absences.
Second.
Well, we
We're gonna need a first. So Dr. Gilbert, you're first. Thank you, sir. And I see Mary Mena saying second there, so thank you very much. So we have that.
We need a vote now.
And I need to take a vote. So all in favor of the motion of excusing the absence of our committee members who are not here, say aye.
Aye.
All right, we have 4 ayes. Thank you.
Guess I need to check my Robert's rules. I thought the motion was then seconded. Sorry.
Thank you. And I'm supposed to ask all of those that are opposed to the vote.
Is there name?
So there are no nays. Okay, so let that be put into the minutes and the motion passes. Thank you. Okay, the next section we have here is for public comment. The comments will be limited to 3 minutes per person, so please make sure you do that. I hate to stop you in the middle of your conversation. So definitely get to your point and get it across, and we will move on to any other public comments. So I will open it public comments. I ask you that if you want to make a public comment, please raise your hand on the chat box and we will recognize you. Please state your name and who you are representing, and then you'll have your 3 minutes. Do we have any public comments? Do we have any raised hands anywhere on the list?
We do have a call-in listener. They can't raise their hand. Do we need to ask them?
Yeah, go ahead.
You can always put something in the chat box too, but if, okay. The one person who's calling on a phone, do you have any public comments that you need to put in? Okay, so everybody's been allowed to give public comments and there are no public comments. So we will move on to the presentations of rule recommendations by each committee work group and review of stakeholder input over the last few days about the assigned anatomical related issues for discussion and consideration by the entire committee. As we go through these work group discussions, our goal is to, as a committee, to discuss the points that were given by the work groups, any input we have, and then we will make general recommendations to the commission about our comments. We will start with the application process outline, as that was the first work group assigned. Who was in that first work group?
Which one was it?
The application process outline, Dr. Gilbert?
Yeah, that was me and John and Bethany.
Okay, as you're the sole member from that group here, if you want to go through some of your points, you're more welcome to. The group all has it now in their hands. Does everybody have a copy of the application process outline that stakeholders had an opportunity to discuss a few days ago? It should be in your email from the stakeholder meeting. If not, let us know. We will share the screen so you can see it.
Let's see here. So what was,
You want to share that screen?
Yeah, let me get. 1 second, let me get it to everybody.
So Sarah's looking forward to try to share her screen so everybody can see it in case you do not have the outline, but everybody should have had the outline from the agenda and also from the stakeholder meetings. Dr. Gilbert, do you have that up on your screen yet? Or do I need to email it to you?
I mean, we can, remember we've got the 2 separate, so I don't know if you want to walk through. With the work group submitted first, and we can go over the application outline that was discussed with stakeholders or whatever, or we can, however you would like to proceed, just let you know there was a difference, so just whatever you would like to do.
Is this Dr. Hubbard here? What participant, is that him there? Or what?
Oh, that's Dr. Hubbard, yes.
I will-
yeah, he just said he was having trouble getting in and told me he was in now, so.
Okay, so let the minutes show that Dr. Hubbard has joined us from the committee.
We'll wait until we get-
And Dr. Hubbard, I just need to see your pretty face on the video and say hello to us when you get a chance.
I got knocked off and I'm back on. Can you see and hear me now?
I can hear you, sir. I just need to see your video there you go, sir. Thank you. Good morning.
I got knocked off and back on. Thank you. The original link didn't work and I got a new link, so
Perfect. Glad to have you on here this morning. Thank you.
I'm skipping out of class. Histology lectures this morning.
That's okay. I skipped a few of those myself in medical
Just,
school.
I'm gonna say just what an anesthesiologist wanted to attend.
Well, I have yourself and Dr. Gilbert as you guys were on the work group for the application process outline. Why don't I give you all a few minutes to talk about your recommendations that are on your sheet here, and then we'll get the stakeholder input also put in there so we can have both sides, and then we can go to general recommendations so the committee can vote on those general recommendations so we can push it to the commission. So
Just emailed everybody too what was sent to the stakeholders.
okay, excellent. So the stakeholders information was just emailed to all the committee members. It'll be in your inbox at your .gov. So Dr. Gilbert or Dr. Hubbard, if you guys want to start by going through that outline process and letting us know your thoughts and kind of research behind things and why you made those recommendations. Some of these are very obvious. You don't have to tell me about the contact name or those kind of things, but you know, whatever you think is important.
Yeah, so I'll go and John, I'm sure will fill in, but so I think there, let's see, I'm looking at the wrong one. Sorry, 1 second. As I was ready to go. Application, there it is. Clicked on the wrong one. So effectively, what we were tasked with, as we understood, was to establish or list a process for how people would apply to be considered as a facility or will body program. There was there is significant there's already the current rules in place are currently there, and so what we tried to do is not reinvent the wheel, but simply redirect some of that content and what we submitted in so that this could be a little bit more streamlined approach. What we're looking at here is, I guess, an outline of some of the main things that we were suggesting to include. And I think there were some forms that either could be shared with the commission in terms of kind of developing those forms, but ultimately it would be general contact information. There would need to be a rationale as to why they want to either open a facility or a well body program, the purpose for what the cadavers would be used for, and then of course, as it lists there, how they were planning to evaluate and maintain their chain of custody. The farther down, I guess that's page 2, just who would have access and use. So effectively, how are you going to maintain the support and of the cadavers and the dignity and respect of the donors, tracking of those donors, the bottom of page 2, procedures for how they're going to be transferred. So really, I think there were 2 different pieces to this. One was how would someone who wanted to start an anatomical facility apply to do that? And it would basically be, in a nutshell, establishing a request with all the contact information. What's the point? What's the purpose? Where is the facility, et cetera, and how the requirements for maintaining the respect and dignity of donors was going to be handled. So, that's a high level view, but ultimately it was going to be gathering all of that data, how cadavers were going to be transported in and out, et cetera. I think there's a decent amount of overlap with some of this with the inspection group, because those are going to be questions the inspection team's going to want to see as well. Interestingly, there's quite a bit of rule that's already written. And so as far as the draft of an updated rule, there's really some changes that could be made there that we had included in what we submitted to be considered. So John, anything
Real
I
quick,
didn't?
sorry, I did just email, because what I had to email to everyone was the outline we discussed in stakeholder meeting. I just in a second emailed to everyone with y'all's what y'all actually, your in-depth documents, since Dr. Gilbert, I wasn't sure what you were looking at, so just in case it was the outline of the stakeholders, I wanted to make sure everyone had your copy of the rule changes, the checklist, and the
Yes.
form.
So what I was just walking through was the outline that the stakeholders reviewed, and we can go through what we submitted as a committee or as a work group, sorry, if that's of value.
So essentially, there are three categories that we have to deal with. There are the NATOs, which are defined in statute, and their process essentially is to be accredited by AATB. That's the process, and then they apply to TFSC. There are willed body programs that have a separate categorization, and then there are anatomical facilities. We have the three different categorizations. I'm going to skip to the inspection process because we have rules for which these categories can operate under. The inspection process simply validates that they are what they say they are. If you're applying as an initial facility, you put that information in the application. The inspection simply validates that this is factual. If you're already existing, the inspection validates you still are what you were. So the inspection is a validation of the application. So it's a duplication. It's so the inspection process simply follows the application, which is a statement that we abide by the rules. We adhere to the rules. This is it. So,
Dr. Hubbard, can I ask you a
Yes.
question, sir? The application itself that I have in my hand, let's look at that for a second. So what I'm going to ask your work group is this application here, does it have all the information we need for a entity that's never applied to apply and put their general information? I understand that afterwards, the inspection will validate the information on the sheet. So my question to the two of you and your work group is there anything that's missing now that we have other entities involved, other groups involved versus what the State Anatomical Board had beforehand? So with this application in hand, I believe this is what we're proposing to go forward. Are there changes or recommendations that you see on this 3-page application that you would recommend to have on here that was different from the prior application?
That's a great question, because that's why I titled it a template, because there are some questions that need to be resolved. Is our final version, is this what we want?
Yes, sir.
On the actual rules, are these what we want? And then we have to reflect those on the application.
Right. So my
There
question
were
to you
some
is,
areas of question that need to be discussed and resolved. So that's why this is a template. In its raw form, it's fairly complete. But there are some areas that need to be changed or we might want to change. So, there's one thing in here. If you look down on page 1, after the name, the address, the person responsible, and we have the categories, NATO, with an asterisk, evidence of AATB accreditation required. On line 3, is this a fixed facility or is this a temporary facility? Does that matter? To me, it does matter. But to TFSC, it may not matter. You know, are we going to hold a fixed facility or a temporary facility to the same standards?
Right,
We've come to agreement with that.
and there's been some definitions that we've thrown around, such as traditional versus non-traditional sites. Those that were built for the purpose of healthcare versus those that are being used as a temporary facility, such as a hotel ballroom versus a gross anatomy room that was built for that purpose. So I think we'll need some more input into this section, but yes, the categories of NATO, will body program, anatomical facility, and forensics facility covers the general groups, and then you can have a subcategory. This is just my thought on your process that you're working on. Is this a healthcare facility? Is this a brick and mortar? Is this a mobile facility, or is this a non-traditional facility that was not built for healthcare or educational purposes, but has been used plenty of times for that purpose? So those are some of my thought processes on the things you guys have on this inspection. And the beauty is now we have an opportunity of the entire committee to look at this, these general recommendations that are coming out from your group and be able to give input into it. Is there anybody else from our committee that would like to put input into this section of the different organizations that can apply? And if there's any type of wording that you would think would be a good idea to have on here, please shout out.
So when you ask your question, is this a finished document? No, it's not. This is a template. And these are some things we need to resolve.
Yes, sir. That's what we're going to talk about right now. Yes, Ms. Manna, you have your hand up?
Yes, I had a quick question, and it doesn't have to do with the application itself, but in order to understand it. And it's on the first attachment that Ms. Hartfield sent on the application and inspection of facilities. On the, because I know I've read this somewhere, but now I can't find it. On 479.2, letter B, it talks about third sentence down, or it says, or existing approved facilities undergoing significant alterations and so on. Do you have, I just taught, just thinking, if I'm an existing approved facility and I am undergoing significant alterations, how far in advance should I be sending that notification to the commission? I know I've read that somewhere, but now I can't find it.
Well, I would go ahead.
Well, Mary, we've discussed this in our work group, which was about inspections, and I have had some suggestions or recommendations on timelines, so that may be
Maybe that's where I'm remembering it. Yeah. Okay.
Yes.
Okay.
So when we get to the inspection section, we can discuss that, if that's okay, Ms. Manna.
That's fine. Thank you.
So were there any other suggestions on the groups and categories on the application process that we need to add in here? Yes, ma'am.
My recommendation would be that we follow, the definitions. I assume that we will have a definitions page or in the introduction of each, on how we clearly define that, versus having bioskills / surgical simulation facility, unless we have all of those, or would those fall, to your point, under the category of anatomical facility? Seems like that this is a little confusing for me as someone submitting an initial application as to where I may or may not fall.
Right. So my understanding was there's, in essence, 3 categories of approved facilities. You're either a will body program, a NATO, or your approved anatomical facility. Those are the 3 by statutes, period. So my suggestion would be that's the first primary category is NATO will body program or approved anatomical facility. If you check will body program, then you will write all the information about a will body program that's focused towards your category. If you're a NATO, then you will fill in the information there. And if you're an anatomical facility, you'll fill in your information that's more specific to your organization or your category, I should say. So my suggestion would be that we break this down into the primary category of will body program, anatomical facility, or NATO. and then a subcategory that if you're a NATO, you fill in this part. If you're a will body program, you fill in this part. If you're an anatomical facility, you fill in this part. And then there are other parts that are very general that you can, add in here as you go along this application process. But once we know your full contact information, who you are, who the person is, contact, all those kind of things, what category you fall under, then going into your other section of general characteristics of facility program. Once again, there's 3 categories here. You're either a will body program, you're a NATO, or you're an anatomical facility. A lot of this has a lot to do with what will body programs were, because that's what the State Anatomical Board was focused on, because there's really nobody else doing this. And so source of cadavers being your first question under the general characteristics of the facility. I don't know if that goes logically down the list, right? So I'm a anatomical facility, and your first question you're asking me is sorts of cadavers. Do we have a different application for a will body program and a different application for NATO and a different application for an anatomical facility? Because there's only so many NATOs and there's only so many will body programs. It's the anatomical facilities that we have hundreds of.
There is another application for a will body program.
Correct. And it should go by the same general format, but yes, it should be focused about what the will body program is about, because there's going to be a lot of other questions that a will body program is going to be asked, crematorium, all those other things versus an anatomical facility. So my suggestion may be that there's 3 applications here for the 3 categories.
Right.
That was focused towards your category, correct? And that way you can get the right information that's more, smart from that organization than just some random information that may not be applicable. Because I know I've filled this out before and I had a lot of not applicables because I was like, I don't understand that question.
And so I just opened up another template that I thought was submitted to the application to establish a will body program.
Right.
So so there the 3 categories, and this is a suggestion that I was going to bring up that Ms. Hartsfield is going to cringe at, is that we have 3 categories. We're going to end up with 3 categories of rules. There is the rules that apply to NATOs. There are rules that apply to will body programs and their application process. And there are rules that apply specifically to anatomical facilities. Some of them will overlap, some won't. NATOs are exempt from a lot of things that will body programs are not. Anatomical facilities have different categorizations also. There are some overlaps in them. There are some separate, distinct things from them. But one rule does not fit all 3 categories necessarily.
Right. No, I understand that, Dr. Hubbard. I think the question here is, should we have 3 application forms for the 3 categories? Okay.
Absolutely.
So let's
And
go.
we have, and we also can have a 4th application. We had a modified application with the Anatomical Board for the outdoor facilities we use for the forensic science and the search and rescue programs.
That's correct. I know the forensics and research organizations that do things outdoors, that may be a good process here for a 4th one. So can we get a general recommendation? This isn't a motion or anything, but from the entire committee, that we believe we should have multiple applications that are focused on the actual organization category?
That's my recommendation, that each distinct category has their own application process.
I understand.
And their own criteria by which to apply to become approved.
I understand. Dr. Gilbert, what is your thought process on having 3 or 4 different applications that are focused on the group?
Yeah, I think that makes the most sense, because the data that we're asking for in the application is more specific. You're not going to have to skip questions or say, I don't know what to put to that. So I think we build the specific application templates for the 4 different categories that we have, and that would make the most sense. So and I think this is a really valuable conversation. Can I ask a question to the group, and maybe Sarah, to try to figure out what our goal for the end of today is? And specifically, are we mostly interested in fixing these kinds of forms, or are we interested in looking at the rule recommendations to submit to the commission for them to consider at their next meeting. And does that all need to be done today? What's our goal today?
So if I may answer first, Dr. Gilbert, the goal is for each of the work groups to go over what they've worked on. And then the entire committee to give feedback on that work group's discussion items. And then to make general recommendations that we will pass a motion on. We have time to go back to these work groups, which will be changed around a little bit. But the work groups go back together and come back with the final rules. And then on the next meeting around August 5th or so, we will have those
Like maybe the 9th, the 11th.
somewhere around there, first, second week of August, we will get those final rule recommendations back together with another committee meeting. Sarah will then take those and formalize them and put them to the commission's August 20.
No, sorry, hang on, let me interrupt just a little bit. So the goal is get like what Dr. Lee was saying, get the substantive feedback today, so I can take those and get formal rule drafts to bring back to the committee at the next, because we have time for one more meeting before we have to get everything to the commissioners for the 27th meeting. And so if I can get solid feedback of really what the recommendations will look like, so I can draft a formal rule for everyone to look at, and I'll get distributed before the meeting, and hopefully that can be the final rule recommendation based on what y'all discussed and recommended. And
But the final goal is that everything we're recommending is proposed formally so the commission can look at and vote on. Is that correct?
yes,
We will have that done. That's my goal, and I think the committee's goal too, is to have everything formalized and submitted to the commission so they can go over it on their August 27th meeting.
Yeah.
So we will have another SAC committee before then. So today we will make our general recommendations and motions. Sarah will take those, put them together in a formal manner, get it back to us on our next meeting prior. We will finalize, look at it, and then we will pass those on to the commission.
and then my recommendation in regards to the question about the form versus the rule. Going through the form is helpful to make sure we are getting the type of information that y'all are wanting the commission to collect. However, I would say, just so it's more feasible for staff to make changes as necessary, that we don't formally adopt a form. It's just, but here's the general requirements of what we need. And then we can take this template and make sure we get all the requirements that are discussed at the meeting and have that on our website.
So you don't have to create the little boxes and check boxes and all the cute little stuff on here. You just need bullet points of this is what we expect. The information we need for a anatomical facility. This is what we propose as information needed. So it'd be bullet points, please. And same with the Will Body Program or NATO's. So we'll make those bullet points. They will take it, make it into a template so we can look at it the next meeting.
Yes.
So
That
It's my-
helps. That helps because we could spend all day trying to fix forms, and
yes, no,
I wanted to get us to the substantive portion of the rules.
absolutely. So right now, I would imagine that the general recommendations, we're gonna have probably 4 applications. We'll come back with bullet points for what each of those applications need, the information needed. We'll get those to Sarah. She'll look at them, formalize them, and get them back to us. So if everybody's okay, for the interest of time, I will move off the application form itself to the next part of the application process, if that's okay. And please hold up your hand if you have any.
Yeah, this will cover all this.
Right. So on your general information, I think that's pretty obvious that what the work group started on and, you know, when they should be submitted and when things need to be updated. We're trying to move some of these things to kind of match what the Texas Funeral Services Commission does with its funeral homes. So 1 year was a recommended length of time for registration authorization. So each year you need to update your, each year we're gonna have to update the,
It would be a renewal.
Renewal.
So in the funerals, with our funeral establishments, they have to renew every year, pay a renewal fee, and then I think that's when they update. Like if there was any contact information change or any tweak like that, that's when they would let the commission know. But we would still maintain the inspections of, the recommended was to make it once every 3 years. I think NATO's per statute have to be once every 5 years. Unless it's a conditional NATO, and then it can also be the once every 3 years. So that was kind of, again, we're just trying to, just for our own staff responsibilities and duties to kind of keep as much as we can the same across the board for all of our establishments.
Now, may I ask, has the Funeral Service Commission established a fee structure yet?
We can't, I think we're having to wait to get, because right now we're operating under board rule that says we cannot collect inspection fees.
No,
But
that's not
four
what
or
I'm
five-
talking about. A registration fee.
We're keeping it at that
Statute
five
says you
hundred
can
dollars.
establish fees.
We have the five
We're not
hundred
talking
dollars
about
that was
inspection
recommended.
fees.
I understand the $500 for the registration, which is what was originally mentioned in the application that came over from the anatomical board.
Now, is that an across-the-board fee for all facilities? Are you going to have a staggered fee for different levels of facilities? Or, you know, are the research facilities, the search and rescues, they gonna pay the same fees as everyone else? Or how is this gonna work?
I
And
think
when
that's
is this gonna be effective?
I think that's the discussion for, part of what we would like from the committee is just saying that the commission, can set reasonable fees to cover the costs. And honestly, what we're gonna have to do is look at what our costs are. I gotta work with our CFO and then, from other agencies, what they do is they divide that by the number of licensees, and that's kind of how they determine what needs to be charged to everybody.
And then will there be an annual renewal fee? Will it be every 2 years, 3 years?
Annual,
going to
annual
work?
renewal fee will be once every year. And that, because right now our funeral establishments, they don't pay an inspection fee, they just pay a renewal fee. And so that's kind of like what we would do for the anatomical side, is that same thing where, so that there's not an inspection, a separate inspection fee. It's just a renewal fee that incorporates all staff travel costs, overhead, that kind of thing.
So Dr. Hubbard, there's in essence two fees. There's an application process fee to register, and then there's an annual fee. These fees will be set by the commission as fair and equitable. And we have to look at the costs associated right now with inspections, processes, staff, and all those things. So we won't be able to set a number, but obviously we want it to be appropriate without breaking the bank, but at the same time being able to fund the anatomical part of the Texas Funeral Services Commission.
And by statute, like, it has to be a reasonable fee, so we're not gonna charge just for this, but it's gonna be based on whatever our expenses are, because also for the legislature, the type of agency that we are, for any appropriated amount that we get from the legislature, we're required to cover our all costs. So we have to make sure that we're bringing in the same amount that we've been appropriated by the legislature.
So the question, establishment of fees, does this need to be part of the rules adopted in Texas Administrative Code? Or can this just be a commission decision that they can change at a regular commission meeting?
I think because there is a current board rule on anatomical board rule about how all inspection costs and re-inspection costs are covered by the anatomical board, which now per 2040 is the commission, that there has to be a rule in place or the commission vote to repeal that rule. And then so it either needs, we need to firmly establish a rule saying that commission staff has the commission may reasonably set fees to cover all costs. Or we just go ahead and repeal the anatomical board rule so that it doesn't preclude the commission from charging.
So the funeral home license fees, is that in the Texas Administrative Code, or is that just your operating procedures?
I believe it says that we're allowed to charge fees, but the amounts are just set by staff based on what our. No, it is in rule. Oh, okay. Just kidding. It's in rule. So I guess we will do the same for the anatomical.
So in essence, it'll be in the rule and the commission will have the opportunity to repeal and put a new value up if they see necessary. Is that a correct statement?
Yes, sir.
So we can just take that rule and revise it that the Funeral Services Commission can establish reasonable and necessary fees to cover registration, costs of inspections, et cetera, et cetera, et cetera.
Correct.
Okay.
If I may continue going down your application process outline, we've talked about the first general information, purpose and cadavers, use in which cadavers will be used. Obviously, we've had stakeholder input, and in this application process, the organizations, depending on who it is, will have to answer why and the purpose behind their cadaver usage, right? If you're a will body program, it's gonna be different information you're asking for. If you're an anatomical facility or a NATO, so we will ask that you make bullet statements for each one of those different groups, which will be quite obvious, but they will have an open box of put input in there. Is there anything other unusual information you need regarding the use of cadavers at each of those 4 categories?
I think we need to put who is going to use them, who is going to supervise the use of them.
Correct, thank you. So
Yeah.
put that in a bullet statement that those are bits of information you want for the purpose or use of the
And
cadavers.
that's in the application outline that was discussed with stakeholders.
Okay,
Yeah.
good. So please put those in your bullet statements, Dr. Gilbert, Dr. Hubbard. Chain of custody too, you know, what is the chain of custody supposed to show? Right, so bullet statements of who received it, how long you have it, where it's going to transfer. So if you could give us bullet statements on those bits of information, I think that would be a smart piece of data to have on that application. If it pertains to that subgroup. Once again, consent forms, you know, there's different consent forms. There's a consent to donate, there's a consent to cremate. And then there's, not that this is a consent, but the donor acknowledgement form. Where that's stored, how it's stored, how long it's kept. Those are things that I think you should give us bullet statements on and about. Record keeping is part of this process, right?
Right.
All these things need to be kept in record and statute, right? Going into page 2.
Sorry, really quick, and some of the things, if it was in statute, I wasn't just necessarily repeating it in rule, it's just we'll reference per statute requirements, blah, blah, blah.
Fair enough.
So,
On page 2, describing procedures to maintain records as per chapter 691. It's there. I don't think there's much there. Please, you guys, I know I'm going through this, but say something, stop me. Procedures in place to ensure cadavers are treated with dignity and respect. So I think that's part of standard operating procedures, how we, you know, a statement about how we're doing that. And I know we've written a respect and dignity form. Is that correct?
I have not finalized it, I can have that ready, but we have.
But that should be something that should be, you know, filed with each of these 4 categories, that they have the respect and dignity form and they follow that. Here's the types of individuals who have access or use of those. So these will need to have bullet statements per 4 categories that we've discussed, which may be different. Some of them may be the same. And I think the things you'll have on here is fantastic. Copy of entities, policies and procedures of handling the cadavers, how they're received, how they're stored, how they're maintained. And I know you go through other things such as transfer and those measures there in your next bullet point. Is there anything from the non-work group committee members looking at these sheets that Dr. Gilbert and Dr. Hubbard may want your input on? Okay. Public health and safety. Once again, I think this is an important part of it. What are cadavers used, operated on, handled, and what types of procedures and process will have occur, and also how you're going to protect the staff, users, and the public from harmful material. Having bullet statements about that. Yes, Ms. Long?
Sorry, I have a question about the prior bullet about procedures for the transfer of a donor. Could we get a definition of transfer? Is it once, you know, there's actual, you know, something physically able to be transferred, or is this transfer of prior, you know, next of kin, or I guess it would prior self-donation applications that then it's determined no longer fits applicability for a well body program, but could potentially fit applicability for a NATO, and then the university is transferring prior to having in possession. Is that understood, or does that need to be?
No, I think that's a
defined?
good idea to go ahead and further define it, because that's not in statute and because I know like transferring may be one thing for just normal our industry compared to when we're talking about anatomical purposes, and there's different rules that apply. So yeah, I think that's wise. So we can work on that.
Okay, so maybe a bullet statement about will body program transfers to NATOs. I know there's times a university may not accept a donor, but a NATO would, because of the different types of limitations or expectations. So that's a transfer, if I understand correctly what Mrs. Long is talking about.
So I don't know that I necessarily see that the same way. If we're not going to accept a donor, we've never taken custody of that body. We haven't done anything with that body, and therefore it would just be a denial. And then the family would then maybe be referred to a NATO? Or are you talking about one that we've actually brought in-house and for some reason can't use and want to transfer?
I know what, because we have done that sometimes, that we have had bodies that we have taken possession of knowing that we are not going to use them, and then we have transferred them to other entities that could use them. It works both ways. We have referred some directly that we knew we were not going to accept. We've taken some into our custody and then transferred them to other entities. So we've done it both ways.
I think, Dr. Gilbert, one's a referral, which I don't think needs paperwork. That's just a referral. And the other one's a transfer, is if A&M takes something, decides they want to pass to a different entity, then that's just a transfer. So having that just defined in essence.
Okay.
Moving on to page 3 of documentation showing proof of compliance with federal, state, and local health safeties of the use of human remains, whether embalmed or not. I think that's just a good general statement. You always have to follow local, state, and federal laws when it comes to health and safety.
I know the common phrases have been used for the different types of cadavers have been embalmed or fresh or frozen. Is there another term that we could use? Because I know sometimes just fresh or frozen, you know, it's not food. We're talking about a human being. So I didn't know if there was another term that we could use as
Well,
conducive to reference.
Nope.
It's either embalmed or not.
But then and with frozen, is there a way where we can say an unembalmed that's been stored at a certain temperature that would equal?
I mean, I know you're trying to figure out terminology.
That's the normal terminology. It's an unembalmed, fresh frozen cadaver. You know, we do that with fixed tissue preparations.
Yeah,
I know it's an unsavory term, but that's the terminology.
yeah. My suggestion would be that we default to embalmed or unembalmed, and then if it's frozen, we add the frozen. But I think the term that we probably could get rid of is fresh, but because fresh is, what does that mean exactly?
Right.
But in all my publications that used unembalmed cadavers, I've used the word unembalmed, not fresh.
Okay.
Can I ask one more
Yep.
question? Because this came up during stakeholder meeting. I didn't realize there was a difference between wholly embalmed versus lightly embalmed. So do we need to also specify those in like our definitions category of what the difference is between fully embalmed and lightly embalmed?
I think it could be valuable because it determines light embalmed cadavers can be used for skills training. Fully embalmed or long-term preparation embalming isn't typically used for skills labs. So I think that could be valuable.
Is that something that y'all wouldn't mind brainstorming with the scientific background of what the difference is between lightly embalmed and embalmed, and I can make it work with the legal part?
If you don't mind, an unembalmed body, all body fluids are retained, and they are frozen or not frozen. And there's, excuse me, an unfrozen body, you have 1 or 2 days before it starts to desiccate. If it's frozen, it will stay in that frozen state as long as it's frozen. Once it's thawed out, you have 1 or 2 days of usage. A lightly embalmed, there is some preservative solution injected, but not all body fluids are evacuated from the body. So it still remains some normal soft tissue characteristics. And those are utilized for generally up to a week. So there is a difference between an unembalmed, a lightly embalmed, a fully embalmed body. All body fluids are extracted. There are long time preservative chemicals in there. Those last for as long as you take proper care of the body. So there are those really 4 categories that you could put a verbal definition under.
That's excellent. Thank you, Dr. Hubbard. That actually makes it very clear.
Yes, thank you.
Okay, if MSDS forms or STS forms are needed for any of the chemicals used, I think that's been out there for many, many years, any of those sheets. So if the facility needs to keep those, if they use those, I'm sure the Will Body Programs keeps sheets on different products that are used. Is that a correct statement?
Yes, there are federal, state institutional requirements for those. And let me make another statement on that. There was a question, and we had this on the little template. Are your chemicals properly stored in a chemical cabinet or some such device? Proper storage of chemicals is something that's we looked at as a requirement. It's not really a requirement in funeral home establishments or mortuaries. There's a difference. There are chemical grade storage cabinets. You go into a lot of funeral home establishments, they're just up on an open shelf somewhere. And then there's a air monitoring where someone comes in, and this is an institutional requirement in educational institutions, where our lab safety officers will come in with monitors, and they'll monitor the air quality for formaldehyde, for phenol, for phenoxyethanol, whatever chemicals you use. That's not a funeral home or mortuary requirement. It's a requirement in our educational institutions. So do we want to require those in these anatomical facilities? That's a question that needs to be addressed. The air quality in these institutions.
If I can address that, the vast majority of bioskills labs do not use embalmed or lightly embalmed cadavers. So the costs associated with having those requirements for a unembalmed, if we're using the right definitions, used at these facilities, it wouldn't be applicable, number one, and number two, it'd be a huge burden. If the universities are forced to do that, or the will body programs are forced to do that through their own regulations, I think that's the requirements they bear. I do believe this is part of the inspection process, how they store chemicals, because there are funeral homes that store in these exact containers you're talking about and cabinets. And so in the inspection process, if an anatomical facility has none of those chemicals, forcing them to have a big storage cabinet wouldn't make any sense. But if the NATO or the will body program does, if NATO is exempt, then that's what it is. But if the will body programs are required by state, local, state, and federal, then that's what should occur. So in the application process, I think in the will body program, do you have proper storage? That's just a question. On the inspection, proper storage will be determined and defined.
Well, and I think you could do that. We could phrase the rule where it's like, if you use these chemicals, you're required to follow X, Y, and Z procedures.
Right.
That way, if you don't, then it's not going to apply. So to go back to Dr. Hubbard's question, because that's part of like what we would like to know on the operating end of the commission for our licensing team, inspection team, enforcement team. Is there a particular level out there that we need to be saying, okay, if y'all use these sets of chemicals to to prepare the body or store the body, then by state, these are already what the state requirements are, and so we can just reference that. If you don't use the body, then maybe you should be operating at this level, like maybe the same procedures that's used for operating room. I don't know. That's just kind of what we were thinking. Is there an already existent standard out there that we could reference rather than having to recreate?
I would highly recommend that you refer to the levels that are out there already, the documents that are out there from state and local and federal.
I guess I'm asking, what are those levels?
Yeah, the only entities that would ever embalm would be the will body programs and the NATOs. The anatomical facilities are not embalming because they're receiving bodies or specimens from those other two entities.
Right.
Now, if you're utilizing an embalmed body, do you need to measure the amount of phenol, phenoxyethanol, formaldehyde in your lab, in your facility? Because now we're opening up a body, we're releasing some of these chemicals. Now, a lot of these are in educational facilities, and their lab safety officers are going to come in. They're going to be required by the educational facilities. Dr. Ali's lab in there, when that's your private facility, that's your decision.
Like TCQ though, like sets, like when you were saying
Sarah,
the lab.
I missed the
operators
first
come in?
part of what you said, ma'am.
Sure. Does TCQ set those when you were saying the lab operators come in? Like, what are these? Like, who establishes the standards that we could?
There are
reference?
federal and state air quality standards per chemical that you declare you're using.
Are they OSHA standards, John?
Yes.
Yeah.
But I thought universities were exempt from OSHA.
No,
No.
No.
Like the,
they wish.
well, I was gonna say, I've had a university attorney tell me y'all aren't subject to them. So no?
It's like all the
We
professors.
get, our university lab safety officers come in twice a year.
So bizarre. Okay,
We're-
no,
we're
I'm
not
not
exempt.
doubting, I'm just getting mixed messages, so, okay.
We're not exempt.
So,
And we get badges put on our lab jackets and they put these big machines in the middle of our lab and, yeah.
Moving forward down your outline on final disposition of cadavers. I'd like some clarification on this. My understanding on final disposition is when you pass as a living person and you have a death certificate, and the death certificate claims 1, 2, or 3 things occurred, that's it. That is your final disposition. And once you're donated, there is no more disposition after that when it comes legally to final disposition. Am I wrong for saying that?
That's as far as the state of Texas is concerned.
Exactly. So after that,
Now, we still have a body we need to dispose of.
I understand.
So how do you dispose of that body?
I understand.
That's
So,
where I was trying to get with the rule.
right, I mean, I understand the legal definition of final disposition is what's on your death certificate. Once you're donated, you've now become an anatomical specimen, right?
Yes,
And not to be callous when I say this, I'm just trying to state the fact that I believe is correct, is now you're an anatomical specimen, a cadaver, you are no longer a living human being. So these rules are different now. So disposition from that point forward, if I understand correctly, is your consent form should clearly define what you will do with these remains. They will be cremated, given back to the family, cremated, scattered, ocean, whatever it is. Those are the pathways of returning the remains, if I would state it that way. Is there any other? Yes, sir, Dr. Gilbert.
Yeah, so I think you're bringing up a good point, and John and I have talked about this, and in the stakeholder meetings, we've heard lots of confusion or discussion about it. The challenge for us is going to be that the Funeral Service Commission is going to think of disposition in one way, and for us, it's going to be slightly different. So I think we need to define a different term that addresses the disposal of the body in terms of what you're saying. We need to define it somehow different than final disposition, because that means different things to other people.
Well, wait, so the only reason we need to probably stick with final disposition is because in statute, when it talks about the chain of custody forms, it does talk about from intake to final disposition.
But
So.
it could be final disposition of the remains. You can still
No,
use the word.
that's what I'm saying,
Well-
like, I think for, that statute is contemplating final disposition of the final remains, not just that it goes to be donated, because if it was that,
Right.
it wouldn't have said
Right,
intake.
correct. So I guess what I'm saying is that the definition of final disposition of the human who passed, and then there's final disposition of the
Yeah.
donor remains, right?
Right. So
That's what I'm
so
focused
this is a perfect example of where the statute is written in a very broad sense, and the rule has to define what the statute intended.
Right.
So I like the term of final disposition of remains.
Okay.
So final disposition of, y'all have cadavers on here / remains, right? So maybe stick to one terminology, and then there should be bullet points on your consent of returns or cremations should clearly define what that family, are you having it returned to them? Is it being scattered? I don't know of any third disposition
Well,
unless you're at a forensics.
I think you can define where you can do a final disposition remains as a more general, where it's defined as something like meaning how the entity, well, I guess you're right. It could be like after use, after the use of the decedent donor is completed by the authorized entity. It's the manner in which the cadaver or anatomical remains are ultimately disposed of, whether it be by cremation, memorial service.
Right, and
or
I
something
guess what
like
I'm saying
that.
is that we can either define every single one of those terms or say per the consent, the return consent that's completed. Now that return consent, that consent there has every specific part, because if a family says, I want the remains back, they check it, they put the address, the contact name, the phone number, the whole thing. So when it is time, you can contact that family through the United States Postal Service, send back the cremains. On here, I think we're just saying any authorized entity, will body program, NATO, or anatomical facility that will end up with the last part of this pathway needs to define in their paperwork what they do with these remains, right?
Mhm.
We either return it back to the will body program or the NATO, or we cremate per state, local, state, federal laws, and the remains are returned back, or they're scattered, or those kind of things. Yes, Dr. Gilbert?
Yeah, so I think that maybe to simplify a little bit, and this probably won't work for everybody, but in our case, we look at the disposition of remains as either being returned to the family or not returned to the family. If they're not returned to the family, then when we're done with our course of study, then we'll cremate and put in an ossuary. Maybe UT Health in Houston might scatter those no return bodies at sea, cremated remains at sea, et cetera. So it might be just simply asking for return to the family or not. For an anatomical facility, the question would be slightly different. Are those going to be cremated locally and scattered, or are they going to be sent? Is the body sent back to the will body program or NATO to be
I think
disposed?
that's per their contract, right? So if the will body program says we want them back, or they say go ahead and cremate and return the ashes back to us, I think that's a specific thing done as a
But you can
master
set-
services
You can
agreement.
set the rules, because I think, kind of pinning off what Dr. Gilbert was saying, is one of the issues y'all probably want to go ahead and consider is whether, if like the donor, like what if it's the Will Buy program or NATO is in another state and they're gonna send it to another state to be cremated, or do we need to make sure that if it's a Texas decedent donor, it has to be finally disposed of in Texas,
I don't
like
think you
cremated
can-
in Texas, return to the family in Texas, unless the family is located. in
Unless there's a
another
law that
state.
says you have to do that, but I don't think you can do that, because there's plenty of NATOs that are outside that want the tissue back. And you can't force them to cremate it, especially if it may be a multi-use, meaning they've sent the whole cadaver, but they want the cadaver back to use for a different procedure, and it would just be a waste of the tissue. if
So
you're
again,
forcing-
that's where we'll run into the problems with our willed body programs who are solely within the state of Texas and the NATOs who are not. And the problem of, what is going to qualify as a whole body being disposed of, which is a question we're never going to be able to come to consensus on. But, I've got access to most of the donor forms from our willed body programs, and they all state that, and I'll read one right here. Upon completion of the use of my body, I authorize the medical school to cremate my body. I understand it's the policy of the medical school to scatter the cremated remains at sea. Very, very specific. And that's legal disposition according to state law. All of these willed body programs have legal documents vetted by their legal teams that specify what we're going to do with the body when we're finished with it. So the state of Texas donating the body is final disposition. Now, how am I, as a willed body program, going to dispose of it? That's in my donor form.
That's
Dr. Ali has a donor form that specifies what we're going to do with that body. Okay. None of us define a percentage of the body. We just say the body. Okay. Now the NATOs are a different story, because their business, 90% of their bodies are partitioned and sent here, there, and yonder. Are we going to establish a rule that says what percentage of the body has to be brought together to qualify as having a body cremated, and if they're in the state of Texas or not? That's a question we're never going to be able to answer, from
Dr.
my
Hubbard.
opinion.
What my suggestion would be is this is going back to your consent form. This is where the will body program has a very clear consent form, and this is what I think that the committee and the commission should put out to these organizations is you need to clearly define the pathway of the physical disposition of the remains, right? And Mrs. Long just showed me to the side that there's a final disposition, there's a physical disposition. We're talking about the physical disposition, right? So I think that's what's to be versus us trying to figure out what percentage, who needs to cremate, those kind of things. There are local, state, and federal laws that protect people and how they get cremated. What we need to just, as a committee to the commission, hopefully the commission to the public, is this is what's expected, and your consent forms should be clearly defining those.
Right.
Okay.
And the anatomical board required every program to submit a copy of their donor forms. The funeral service commission should do the same thing. You're a will body program in our state. You need to send us copies of your legally vetted donor forms.
That's on the
If
application.
you're
outline.
going to practice in our state, you send us a copy of your legally vetted donor forms that specify final disposition.
Agreed. I think that's the final disposition of the physical remains.
And that was what was
Right.
presented to the stakeholders in the outline.
And I like the definition of final disposition and physical disposition, because it really does separate two. Final dispositions you pass, here's what you're doing. Physical dispositions, this is what we're doing with the remains
Okay.
afterwards, and that's down to the will body programs, NATO's and anatomical facilities. Dr. Gilbert?
And that goes along with another way to put it would be, final disposition is donation, but disposition of donated body would be effectively equivalent to physical
Disposition.
disposition. So either one of those is probably fine. They just need to be defined in the rules, I guess.
So moving forward on description of internal disciplinary measures, should there be unauthorized use? So my thought process on what you guys have written here, this is all your standard operating procedures. If this happens, this is what our group does. If this happens, this is what we consider authorized personnel. This is what we consider security. And all of these are parts that I believe is part of the inspection process versus trying to describe out, this is what we do if someone does something, this is how we discipline them. There's also, the universities have their own disciplinary, I'm sure, pathways if a student or a professor or whoever is involved with anything that's unauthorized, as is our anatomical facility, someone does something, right? Which then goes down to cell phone and video and photography as
Which for those, I was wondering if we could talk about what the committee's recommendation are for cell phone use and video and photography. Because I know there's been, the way that certain photos have been taken of decedents, it's been viewed as abuse of corpse. And so, I know in some capacities it's going to be needed, but I think it would be good to go ahead and set forth what is acceptable versus unacceptable use.
So I think this is an important question and one that we need to deal with carefully. But again, I think this goes into the donation paperwork, because if the paperwork describes the fact that the person has agreed to having pictures taken for various educational or research related things, they've given consent for that. I do think that what we would need to do is make sure that whatever rules govern this, that its efforts are taken to be certain that no identifying marks, tattoos, birthmarks, facial recognition is handled in that accordance. So
Dr. Gilbert, and kind of what you stated there, once again, back to your consent form of this is what this program does, right? So if you're a facials plastics organization,
yeah, sure.
You're gonna have to show the face, and
Right.
they may do educational videos to be able to show that to their students or to kind of instruct their physicians or people in that field. So in the consent form,
Sorry, go ahead.
but my thought process is every effort should be taken to keep the specimen, the anonymity there and also unidentified. Now, if there's a big tattoo on the face that says Mr. Smith on there and they're doing a facial thing and this person has consented that I don't care, I know this is here, then I think that's something that should be on your consent form. I think where we're trying to keep is the bad actors of someone doing a midnight autopsy and showing people. So
Even where students have posted on social media.
correct. So, and that's the part of it is there are a lot of educational things on YouTube. You can look up probably 1,000 plastic surgery things right now on YouTube of them doing things. Now, once again, if it's just showing the shoulder or the ear and there's no identifying marks, then I don't have a problem with that if it's education related. Now, where we may get in a little bit of gray zone is how do you decide that this is more social and non-medical? The judgment may be different because someone may say, well, I think this is very educational, very medical related. You just may not think so because you're a professor and you think differently than I do.
Does the medical board allow YouTube for like medical school purposes? Do you know?
I mean, yes, we have to. I mean, you have a full, now what I can't do is take a picture and put it on my LinkedIn and say, look at this great lab we didn't have a full body with the face showing, but I could show an arm as long as it doesn't have identifying marks on there and say, we had a great upper extremity lab. with so-and-so organization, and these are the things we did. But I think it's the identifiable marks is what I would be concerned about, unless in the consent, that patient has said, I don't care, I have identifiable marks all over me.
But
See a lot of-
patients give consent to be photographed or videoed during that procedure. Cadavers give consent to be used for education research purposes, but you can't show identifiers. You can't show the SAB number, identifying tattoos or something. You can put a black or a gray mark over that picture or that video to de-identify them. HIPAA rules protect cadavers for 50 years. You're protected for 50 years after death.
So
Okay?
can I ask that question, because when we've had to submit public records, there were some where it did have some identifying remarks when we asked the OAG ruling on it. And they said that the privacy diet ended at death. And so there are certain things we had to go ahead and disclose, even though if they were alive, we would be required to withhold it. So do you know particular, and I'm truly out of curiosity, because I want to make sure that we are, doing what we need to do to protect the decedents. Do you know, or maybe your attorney knows, what particular parts of HIPAA that would apply after that we can go ahead and incorporate or use?
I don't know the specific statute or line in it, but just that general was that HIPAA applied for 50 years after death.
Okay.
We can have that looked up, but
So if I make a
Correct.
comment, if I can make a comment about that, that's if they're not donating.
Oh,
So what I'm
okay.
concerned about that statement, Dr. Hubbard, is once you have donated, you have now become part, you're an anatomical specimen. And HIPAA no longer applies to you. Now, if I pass and I just go the simple path of burial or cremation, yes, my HIPAA is protected. Now, all of these patients' HIPAA, their prior medical history is shared. Their serology is shared because we have to, because the organization's expected, because we want to know. The World Body Program share with us heart disease, HIV, because we have to know. So that is not a HIPAA violation once they become an anatomical specimen, from what I understand.
Yeah,
Can
so if I can add a piece to this, John, I understand what you're saying, and I agree to a point. Aaron, I think you're right. I think that that the death and the donation process has some effect on that, and here's why. At this university, at TTUHSC, the IRB, the Institutional Review Board, does not review research-related requests that's done on cadaver material. When I started my research 20 plus years ago, I went to IRB and they said, we don't want to know, we don't care, because it's not a human subject, it's tissue. And so when we established the Institute, we established an approval process that functions like an IRB, where we have a committee that approves the use of that specimen for a specific research purpose. It's not an IRB, it's not near as rigorous, but it does make sure that the people aren't just doing random stuff and we don't know about it. So I think there's probably a both and here, but I do think that those questions are important, but maybe that helps the context a little bit.
And what I would recommend is, we have a cell phone video photography policy form. So if any organization says we would like to record this, they take our form, we walk through the form with them, and they sign off on the form, so they know what we have set as a standard at our facility, and that these are the rules and regulations involved. So they are very clearly defined to our clients who may want the video for educational purposes, and they sign off and we sign off, and we keep that in our forms, right? So if later on I find out that this thing's on TikTok and we went through our process to protect the donor and to protect our facility, now the onus is on them for signing a document that said, we understand, and they broke that. So what I would recommend as a rule is any facility that has a cadaver, whether donated to or used, should have a policy written regarding cell phone usage, social media, photography and videography, and what is clearly defined from your institution.
Yeah, and that's exactly what we have in terms of our human gross anatomy use form. And then if a group wants to use picture video, they submit a request, we have an authorization form that they can submit to, let's say, a journal publication that says, we have the authority to have these images and they're appropriately used. And this was an appropriately approved project. So I think the issue really boils down to medical journal publications. Those things are not an issue typically, but we need to authorize them. But the issue is really stuff ending up on TikTok and wherever else. And I think the form that you're talking about, Aaron, and the one that we used, and I'm sure John has one too, is our best effort to say, hey, users of the lab, you can't just come in here and take all kinds of video and pictures and post them wherever you want. So I think that's an important piece. I do think there's one caveat that we should consider, and that is, I think that I read somewhere, maybe it was AAA, American Association for Anatomy. I think there are some best practices that are described related to video and whatnot, and specifically as it relates to products being developed that are going to lead to remuneration. So if we were going to develop an anatomy app or something that was going to be for training and make money on it, it may be that there's another layer of consent that needs to be discussed there. So I don't know, that might muddy the water, but I think at this point we should have a form that, or the facility should have some type of form that they submit that says what their policy on video is, and we should have a framework that they use.
Usage agreement.
Yeah, I like that, a usage agreement. So, okay. And then on the legal and disciplinary, kind of going at the same.
Wait, can I go
Yes,
stand
ma'am.
up real quick? So, because I know the underlying issue for the commission is again to make sure that the decedent donors are treated with dignity and respect. And so, again, I know y'all all have your best practices, but to help us who again are not in this every day, is there a little bit more than we can do of just making sure that there's a cell phone video policy of how things are used? Can we have a little bit more guidelines of what that, we can keep it general, but of what that should entail to make sure video, photo use is, while maybe advancing medical and forensic science, is also protecting the dignity and respect of the decedent?
I think one of the rules should be that, we have a dignity and respect form and that they should refer to that. And then number two, that there should be no identifiable marks that can lead to the identification of the specimen, right?
Right, but I guess because I know you were saying in some aspects it's okay to post on YouTube, some it's not. Like I know
So-
when we were for out of state, we were looking at closed circuit was allowed, but if it was.
But then I would get to define that if there is video or cell phone pictures or whatever it is that is used for medical purposes and not for social media.
Okay.
I think if you have that part in it, it keeps it general, but at the same time, if someone puts it up there with a double thumbs up next to a cadaver head, there's nothing medically education related about that, right? Versus I am showing something on YouTube on how to remove a mole off a person's face, and then there's an educational purpose behind it, right? So I think if you leave it in those general categories of educational research oriented versus a social media type post, then that helps you be able to kind of discipline the right category. Yes, sir, Dr. Gilbert.
Yeah, and I think too, we could list a phrase in there of efforts will be made to protect the identity and dignity of the body or the donor. If you're doing a facial procedure, you can drape or cover portions of the face that would make it harder to identify. And then we can list something about trying to be attentive for identifying landmarks or something like that. So I think we can come up with some text. We have some in our forms I think we can use, but I think this is an important issue.
Ms. Long.
Yeah, I guess question or, comment is, in each of your facilities, is it that only authorized users of recording or photography devices are those that are allowed to capture such? Versus, anyone that has a cell phone can capture it, but then as long as they've signed their, waiver and then they're attesting to not doing.
No.
things.
Our use form says that videography and pictures are not allowed unless prior authorized by the department.
Ours is a little different. Ours, it has to be taken on an institutionally owned device and stored on a password protected hardware that only the faculty or the lab personnel have access to the password. So it's got to be password protected on an institutionally owned device and then used for educational, research, or medical purposes.
I think that works very well at a university setting, but I think
Right.
when you get to anatomical facilities, that becomes very difficult. But I think the gist of it is authorized people should be the only ones allowed
Yeah.
to record following all the usage agreements that are
Right.
done, and also per your consent for your organization.
So, you know,
And-
so
and written
Dr. Ali's in your own facility, you have your form that they acknowledge the restrictions. Okay, they have signed an acknowledgement. Our students right now are signing a form saying they have read my lab policies and procedures and regulations and sending them in to me. They have to do that before they set foot in the lab. That's a requirement.
Yes, sir.
If they don't
Yeah.
sign it and submit it to me, they can't come into lab on the first day.
Correct. Same with us as you enter
That's
our
a
facility.
policy. You
As you
have
enter-
your policy that works for you.
Right.
So-
Yeah, as you enter our facility, we have a QR
Right.
code that you have to scan to sign a lab waiver that has all of those things in there very clearly, that you can't do this, you can't do that.
Okay, so one policy doesn't fit everybody.
Right.
But each entity ought to have a policy.
I think
that
that's
works
the
for
real,
them.
I think that's one of the real recommendations we should think about, is a statement that says, you know, though I can't tell you every single piece of your policy, but you must have a policy that clearly defines usage of videography, pictures, those kind of things, versus us telling them you can't have it on TikTok, but you can have it on YouTube. That's, I don't think the commission's, or excuse me, the committee's responsibility to give that recommendation to the commission. I think there should be a clear definition of what we're recommending, that you must have a camera usage agreement, dignity and respect, a waiver you sign, whatever it is, right? So that's what I think we should be doing.
And used for medical education research purposes
Sure.
and not uploaded to what we use the term publicly accessible sites.
Yeah,
But,
Dr. Hubbard, that gets difficult because like I said, there's a lot of stuff that's done on publicly accessible sites. I would say more social media versus medically educated.
that's my definition.
Sure.
But yeah, and I understand the difference. But you know, we have strict restrictions in my program.
Sure, I understand.
So
If I may move on to the legal and disciplinary history on your application process of, we expect these items to be alerted to the commission if you're applying, and I don't have any issues with the statements that are made on here from your work group.
Well, that was our licensing team, so that was why I wanted to bring it up before
Sure,
everybody.
absolutely, yeah.
Because we were kind of like trying to figure out what would work based on what we currently do.
On page 4, the next page, license authorization, certification, registration, another state. So
Is this saying like if they were also disciplined in another state, or because that's what we do for our current, licensees.
now, I have somewhat of an issue with that, and I've had that since the Attorney General's ruling 5 years ago. If I have a Texas driver's license, I can drive in New Mexico. I understand that. But I'm still bound by the New Mexico rules when I'm in New Mexico. Someone that has a authorization to run a program in the state of New York still has to abide by the state of Texas rules if they want to operate a program in Texas.
Agreed.
Okay,
I think
so
where
the
we're-
fact that they're registered in New York, to me, has no bearing.
Sorry, so I think there's a little confusion. So where we're coming from is from the disciplinary conduct part, is if they are registered or authorized or certified in another state, provide that information, and then if there was any disciplinary history, like if your certification or registration was ever disciplined by that governing body in that other state.
meaning you have
That's
to
one of
you have to tell us
That's
everything.
Okay, well, from the way these bullet points are, this is a separate bullet point from legal and disciplinary history.
Sorry, it was meant to be a combination of both. If you're registered and authorized in another state, and then if it was, because that's what
Okay.
we do with, so that was my bad, but that's
Okay.
that's the
All right.
intent.
Okay, thank you.
Yes, sir.
The next
Okay.
section talks about one-time events, labs, trainings, application for authorization. If, my understanding is you still have to fall in one of the 4 categories. So this part just falls into what we discussed a few minutes ago. That it's the same exact process. You fill in the application, if you're A, B, C, or D, and then you go through the exact same process. So mobile unit, it doesn't
Same
matter, same exact 4 applications that you have to pick one of them.
So I guess the question from our licensing team is for the one-time events, trainings, are there any additional requirements that y'all think they should have since they're not built every day for handling cadavers? Like I know that, like, I guess the plastic that goes over the foot.
Well, my recommendation is that's the inspection process.
Okay.
So you can apply,
Okay,
you can be at a florist country store
okay,
and you can apply,
okay.
because it says, there's nothing in the statute that says you can't apply. I think the inspection process is where we say,
Okay.
do you qualify with all
You
those?
can have something in that room you're sitting in right now
Right.
if you meet all the standards.
Exactly. I thank you.
Okay.
Once again, the next part of the NATO's is another, you got 4 categories to apply to, and you go through the process. We do have conditional versus regular registration. Statute talks about AATB. Sometimes that's impossible if you don't have cadavers coming in and doing a conditional, because AATB does not offer a conditional process, which I've asked directly myself. So having a conditional registration with the state of Texas falls with your NATO application, and that should be something that's stated in there.
And I think too, for the conditional registration, it's gonna be probably equivalent to whatever all the general requirements of the anatomical facilities.
Absolutely,
The
yeah.
bodies that
Yeah.
apply across the board.
Correct.
I just didn't know if y'all wanted anything else.
No, I
for
think a
conditional.
conditional group should follow exactly what the anatomical facilities or will body programs follow, right? Because you can't follow ATB until you get to that.
So in Texas, you have to be accredited by AATB. You can be in application process.
Correct. But when you're in the
Okay.
application process, you must
Right.
follow the same rules and regulations as
Yes.
W.
So you're
will
still
body programs.
applying as a NATO. You're not accredited yet, but you're in that application. So you're conditionally accredited
Right.
pending their inspection, accreditation, formal accreditation. So there's those 2 layers,
Yes, sir.
but it's still the same process.
I would agree. That's the application process outline work group, and thank you for those that were on that work group and all the help and work you guys put in, also with Ms. Kemp on getting that all together. So thank you very much. Is there a final statement or anything that anybody wants to put in there?
Well, I guess it was a pleasure to work with John and Bethany. They did a great job. As far as moving forward to make sure that we know what our call is, then we take the stakeholder meeting application process outline we just went through, and we flesh out in more bullet points those pieces. We don't need to worry about the forms. And then the next piece would be the text for the rule drafts. We have the original, and then we have the ones that we've suggested some of the updated language and changes. My assumption is we're going to just make sure that the bullets in that draft match, and then we resubmit that. Is that correct?
Yes, and then I would just say, because again, I'm just kind of looking, I gotta make sure my bandwidth catches everybody too. Do y'all think that, with what we discussed today and the stakeholder input, do you think you could get a more detailed bullet point list to me by next Wednesday, or do you think, I know Dr. Hubbard, I'm sorry, I forgot you have classes going on right now, so, a week.
I have break from class the first 3 days next week.
Okay. So
They have a boot camp. They're sequestered. They're going to learn all their
okay.
skills of a first-year physician next week.
So
Okay,
Sarah, if I can make one recommendation, when we get to setting these work groups at the end, or agenda, because we're going to set work groups, I would make a recommendation that I would like to put forward that the work groups only have 2 voluntary members on it, with myself being the 3rd. So I may be on each of the work groups to have some continuity between the work groups without creating a forum. And so anybody who's on who's on two work groups, I asked for one of you to step off to make the work groups two. So then I can help out with this work group two with all the bullet point statements. And I can help out the inspection process and the distribution of bodies to have some continuity in it. So if someone is on two work groups, that asks that you step off one of them. Because I think, Dr. Gilbert, you're on with me with one group, with two of us on there.
Yeah, I can step off of this one if I need to, and that would
you.
create some flexibility. So that's not a problem. I'm glad to participate. Bethany had some good thoughts, and I think since she's not here, I would hate for her to be removed and not have that input. So I'm glad to step off. By the way, I'm going to be leaving for vacation on the 31st, and we'll be out for 5 or 6 days till August 5th. We'll be coming back the 5th, so I'll be back in office, I hope, on the 6th. So
And
I will.
that's okay, because with me being on that, I can help a lot of the process to move it forward while anybody's out or with classes.
And I can contribute some bullet points until I leave.
Sure.
But yeah.
I'm going to push the committee members to get this stuff done quickly, efficiently and smartly to get
Could I
it.
get it on a rolling basis just to help?
Absolutely. And it's not you have to wait till the whatever date we pick. You can start getting the stuff in with even sections as you get it done, which helps Ms. Kemp, because if she gets it all at one time, it's a lot of work for her to get this all turn into legalese and get back to us. So if you get the very first section done, go ahead and send your bullet points in as a work group, and we can kind of move forward that way. So Dr. Gilbert, you're going to step off that. We can reassign these work groups at the bottom of the agenda, but then it would be Mrs. Wright and Dr. Hubbard, and then we'll keep the other groups as two people also.
Yeah, that's fine with me, and I'll contribute any way I can.
Okay, thank you, sir. We are going to move. Does anybody need a 5-minute break to use the bathroom or anything like that? Okay, as one of us needs the bathroom, can we take a 5-minute break, please? It's let's go to 10:55. That's like 7 or 8 minutes. That gives everybody a moment longer. So we'll come back at 10:55 and we'll adjourn for the moment. Thank you. Mary and Carrie back. Okay, it looks like we have everybody's faces there, so I'd like to bring the meeting back to order and quickly make sure we have a quorum. I see Dr. Hubbard, Dr. Gilbert, Mrs. Mena, myself, and Ms. Julie here next to me, so we have a quorum. Do I need to take a motion on that, or is that just the fact that we have the quorum? We're good, okay. So we have a quorum, we can restart our meeting. I got a request from one of the members to talk about the distribution of bodies next versus the inspection process outline. Does anybody have an issue of just kind of going to the third work group versus the second one?
For the inspection,
So just skip that for a second, come back to it, because that's gonna be,
I think as the inspection is going to, some of the standards may apply to both in-state and out-of-state. As long as we get to the inspection today.
oh, 100%, yeah,
Okay, okay,
we're gonna get to all of it.
okay.
So the next work group was the distribution and determination of, it's.
It was
emailed
emailed,
it.
sorry.
I've got it here.
I don't think we had it printed well.
I've got it right here, but I think everybody else should have had it emailed it to.
Would you mind, you want him to share it on the screen? just
Yeah,
so
that, I
it's-
think that would be very
The one
helpful.
that
When
we.
you send it.
Mhm, yes,
This is
please.
the determination of distribution of.
input, is that the one?
It was the determining, yes, well. So it's the one sent earlier this morning, probably like around 8 weeks.
Oh, that document,
Yes,
Word document.
yes.
This one. Wants to load, it is not.
Yes, that's it.
Any particular page you want to start on, or just?
I think they're gonna, y'all already know the statutes.
You already know the statutes.
More for the stakeholder
Right, but
reference.
our work groups,
Yeah, why don't you go down? When I incorporated most, I think I just reordered some of it. So start with, keep going down.
it's either this
Here.
one.
So I. so this is-
Oh, here it is. Okay.
Yeah, I was gonna say, I kind of like, I would put y'all's words, because it's kind of done with,
I got it.
the inspection, so.
Am I sharing this page?
Yes, that's the correct one.
Oh, dude.
Okay, so we will now discuss the work group that worked on the input for determining the needs of Texas and the distribution of these anatomical specimens to the authorized entities involved. On the determining the needs of Texas, myself and Dr. Gilbert were on this work group. I'll just start since I'm talking currently, but determining the needs of Texas, what we did is we looked back in the historical data provided by the willed body programs over the last 4 or 5 years, and the amount of bodies that have come into their processes, the willed body programs, and the amount distributed to the state of Texas and those that were outside of the state of Texas. And if you scroll down at the very end, there's a
Keep going. It's like.
there's a scale, there's a graph at the very bottom. Right there, you just pass it, sorry, go back up 2 pages, keep on going, you'll see a little table, keep on going up. It's right there you go. So we thought the best thing is to just look at historical supply and demand, and I hate to use economic terms in this, but this is exactly what it is and what's come in and what's been sent and used since 2018 to now. Last year in 2023, there was 4,189 cadavers that were taken into the willed body program system, with the largest university being UT Southwestern, and then Houston, Texas, UNT, and Texas Tech. And then there's some other willed body programs that take just what they need for their university. And what, as you can tell, the trend from 2018 to 2023, it's kind of gone up about 10 to 20% every year. COVID flattened out a little bit during 2020 and 2021, but as we exited COVID, you see 2022 going to 3,800 and then 2023 going to 4,100. We estimated that there seems to be about a 10% growth. There's a plus or minus here, so we added a little bit to that to say in 2024 we'll have about 4,400. If you see the state distribution, one stakeholder discussion we had for a while with all the university programs is, could this need all of a sudden change dramatically? And I think what was clearly made by the stakeholders is no, any program such as a physical therapy program, medical school program, dental program takes months, if not years, to determine more students being added. And then the physical structure of these buildings to be able to allow more area for the dissections to occur, it takes years to be able to build that out. So a jump in need would be hypothetically wouldn't happen. But it was discussed ad nauseum as to could this happen? And I think all the stakeholders' input was, no, it does not happen. We have long-term standing relationships with these organizations, schools and colleges and other entities. And we know in advance what they need. And their deans and program directors know usually what they need, though every program starts at different times. Physical therapy may start at a different time versus dental versus medical. And those needs are assessed as we go along. And the willed body programs do not receive 4,189 bodies on January 1st. This is a rolling number that slowly adds up throughout the year. So if you break those up into 12 months, you can get an average of what those have. So that was one part that was discussed of, is there a giant swing in need all of a sudden? And the close to unanimous input from the stakeholders was no. And then number two, there was a discussion on should there be a surplus kept? And there was back and forth about what surplus looks like, who should be held in the surplus. the first statement we're trying to answer here is, has there ever been a need not met by the will body programs in the state of Texas? And I think it's clearly shown here that it's always been met, and that the will body programs have worked very closely together to be able to refer one to the other. They tried to refer geographic locations first to who's requesting. And if that geographical will body program does not have the opportunity to provide, they refer to the other will body programs. So,
I got a little bit of input from.
yes,
this
ma'am,
morning.
please.
So we did dive in a little bit more onto like the projected needs intake for January 1, May 1, September 1. And we, through conversation with the stakeholders, it was discussed that it would be good to divide that into categories of embalmed versus unembalmed, because most schools, since we're trying to put priorities on schools and colleges, I believe the bulk majority, if not 100%, all need the embalmed. And so that way, as we're determining in state needs later on, we know that the priority with schools and colleges are given
Right.
priority or
And-
are met, I mean.
My understanding from working with the will body programs since 2011 is they always have fresh, unembalmed bodies that are donated. The vast majority go through the embalming process. And there's always a small percentage, 10 to 15%, that are kept in the unembalmed fashion for other organizations that don't want embalmed. But their 90+% of embalmed specimen will provide for all the schools and colleges. And that's what we want to determine is that happening? Will that continue to happen?
But I think to help us know if it will continue to happen, we'll have them give us that
Sure.
vision of.
It's the data from them, right? And so one of the,
Let me interject something real quickly, if I may, since you brought this up, Sarah.
Yes, sir.
In reality, there are only 4 will body programs in the state that are capable of storing unembalmed bodies. And they are going to supply those bodies to the entire state. So you're going to rely on those 4 programs. And if you want a guaranteed supply of unembalmed bodies, you have 4 options to choose from.
And those schools were on the stakeholder meeting this morning and we discussed it.
Okay.
So, UNT, UTSW, UT Houston, and Texas Tech were all present at the meeting this morning when we discussed this.
Right. Those are the only 4.
Yes, I know.
Okay.
Thank
All
you.
right.
No, I
So
think
you're
that's-
aware of that.
I think
I
that's
have
clearly.
talked with their attorneys too. So
I
we're
think that's
good.
clearly stated, Dr. Hubbard. What the work group's goal here was, how do you determine the needs? We look historically, we see that the needs have always been met. Going
Right.
forward, how do we determine what the supply coming in? And one of the general recommendations is that every university, or will body program, will produce the data on a monthly rolling basis to the commission showing what's come in. So we can continue on you can call it a matrix, you can call it a Excel spreadsheet, whatever you want to call it, to keep a running tally of all the will bodies, inventory and census coming in, right? So it continues to show the trend from historical data to current data, and this should be updated each month by the will body programs. Whether you want to do a month, every 2 months, we can discuss, but let me stop there. That's one of the recommendations, to be able to understand the supply coming in on a monthly basis, so we know what we have. And then where those go will be the second discussion. Do we have input from the committee on that determination of what the supply is on a monthly rolling basis?
Before we do committee, can I let you know, because this is as far as we got with stakeholders, so I can just add a little bit more of what we discussed, and then, then that way everyone has all the data. So when I spoke with our stakeholders this morning, I know the will body programs are saying that some of the smaller schools may not be able to give may not be able to do the 30-day, but they could do like 60 days. But they're saying as long as the commission, so I think in the past, how it's operated is gonna be a little bit different maybe than the commission, where like when let's say if an anatomical facility is working with a will body program, that will body program couldn't meet the need of the anatomical facility, then the anatomical facility would contact the commission, be like, we have this, our normals entity can provide it. So then the commission would, let's just say San Angelo State. I shouldn't use Angelo because we're trying to focus priority on, schools and colleges. So let's just say San Angelo University, or Angelo State, where they then email the commission and be like, we had a jump in enrollment, need 5 more cadavers, our normal supplier can't provide it. Then the commission would email all the other will body programs and they kind of come together. So that's, I think, where we were talking of that 30 days should work, because the larger will body programs should be able to provide that, but it still protects the smaller ones from having to be required to keep the storage or provision or something like that.
Yeah, exactly. And thank you, Ms. Camp. And I think first, I just want to ask the organization, the committee is the process of the will body programs updating their inventory on a monthly basis so the commission knows what's there, so at least the numbers can show historically with the data that it's going to stay around the same, if not increase. I would just like input on that if there is any.
Yeah, I think if that's what the commission wants, then we can do that. I think that it would be feasible, as I think you and I talked about in our work group, Aaron, that we maybe provide quarterly reports that would kind of be that running total on a quarterly basis. Those dates would also potentially coincide with request dates so that we could determine the availability and need. And let's say that in the first quarter, we suggest we have this many projected needs and this many projected intake. At the second quarter, we would need to provide data to show what the actuals were. So I think that's the way that it fit in my mind. But whatever the commission needs, I think we need to.
Well, I
do
think
it.
it's for us to recommend to the commissioners what we think is the best practice. If quarterly is better and easier and less stress on the organizations to try to get something in a month, and it has fit that way, because I know for the will body programs, y'all have met quarterly and discussed these needs as you've gone along. That to me, I think is a fine recommendation as to the supply input. And we'll talk about determining where they go afterwards here.
Yeah, I would recommend quarterly. And again, I think we're going to have to be clear in what data we're actually asking for, because it may seem as though it's easy to say, we have this many and this many, or because we may have this many, but some of them are already quote unquote assigned or spoken for. Therefore, what number are we really looking for, and how are we going to track that? So the categories of intake is going to be important. Sarah, you've seen some forms, and I think Aaron, you've seen our forms that we use for looking at projected need, because we know what we're going to need before the university asks for it, because we have those relationships that have been described. So I think it would be just important to make sure we have those category names so that everybody knows how to submit it. Sometimes it can be confusing if you're talking about how many cadavers did you take in? Okay, well, did you have a surplus from last year? That needs to be considered in the starting number, if that makes sense. So we can get this worked out, but I think to answer the question of timing, quarterly is important so that when requests are considered, we can look at the quarterly report that just came in and say, do we or do we not have the availability? That's my point.
Right, and I think one thing that's extremely important is there's never been a failure in supplying, period. So as we do this, you can see the numbers. We have a 100% excess in essence. If only 2,100 bodies were used for in-state, and we have 4,100 bodies. I don't think that's the issue. I think right now is if the recommendation is we update quarterly what's come in and be able to keep that tally going, so from every will body program what's come in. We'll go into what it's assigned to on the demand part, right? So we're looking at supply right now. So our recommendation seems like we would like the will body programs to submit a tally on a quarterly basis, and we can call it a fiscal year of January, February, March is Q1, and then so on and so forth for Q2, Q3, and Q4. So Q4 would be December 31st. So the last week of each quarter to have those that data submitted in to the commission, so it can be uploaded into the supply matrix, so you can see what's coming in. So that's just knowing what's coming in, right?
So I would suggest that you need a total number of available. You need to know what comes in and what goes out.
I understand
You need to know how many we have used in our program, how many we have dispersed already. You need a total number of available cadavers. So I'm maybe anti-conformist. We know generally a time frame of when these schools need the bodies also. So, you know,
I understand, Dr. Hubbard. What I'm
August is
saying
a
is,
big dispersal time.
what-
So July would be a good reporting month. And, you know, because that, you know, we send a lot of bodies out in August because August, September is when a lot of these programs start. But the commission needs to know how many bodies are on hand, not just how many we took in, how many we sent out.
I understand, Dr. Hubbard. What I'm saying is this is a two spreadsheets in essence. One is what's coming in and then what's assigned out and being sent out, right? So I get what you're saying. I'm just trying to break this down into two processes. One is we need to know what's on hand in inventory
Well,
on a quarterly basis. And then on the second spreadsheet, we need to know what's been assigned out, right? Even though it may sit in inventory, it's not being sent out till August 1st, but it's been assigned. So that SAB number or that cadaver number now is assigned and being used. So we can see that on a simple bar graph, what's in and what's being asked for. The bar graph for supply is always green and never below. And then that can show how that goes. After one full year of data on this, then it's just a rolling quarterly supply and demand spreadsheet that shows. And if anybody comes in new, they get added into the entities of the request form. Yes, sir.
wouldn't you send that in on one report? I don't see the need for two separate reports. And if we send this in every month, you're going to get inundated with information. But so,
Dr. Gilbert?
Yeah, so maybe Aaron, I think we've sent it. I think Jason may have sent it, but we have one that the terminology is basically projected need and time. So projected need, time needed, and fill requests. So once it's filled, it's out of the surplus inventory. So that's what I was saying. We just need to get the titles of the data laid out in an appropriate way. And I think that Jason's really put together a nice way to track this. But ultimately all the will body programs that do this are going to need to use the same structure so that because what John's saying is that if, to use Sarah's comment, if we're supplying Angelo State, which we do, and we know that they need 15 bodies and we have those 15 bodies and we've assigned them, well, that need has been effectively met, and therefore we don't need to consider that 15 and needing to come from a surplus because it's already projected to be met. If that makes sense.
I know. I'm sorry. I guess my mind works differently. That this is very basic. I understand that it's assigned, the inventory is taken off,
Right.
and it's just basic economics. You've got something in inventory, it gets assigned, it gets taken off the inventory to be able that it's not available anymore. And then that's assigned to whatever entity. So you can see that what's been asked for can be supplied by the entity that has a supply, and that continues to roll. And Dr. Hubbard, that's what I know you said the monthly thing, and I had said monthly too, but I think quarterly may make it a lot more simpler. But as this continues to run and build, I think it makes it very obvious that the supply is always there for the demand. And if anybody needs more, then we can show what's not assigned, which is now the surplus, right? Since we have historically noticed that there's usually not someone that all of a sudden comes up out of nowhere and says, wow, I need 15 or 20 bodies, that's not really a realistic hypothetical situation. Then we can determine that this is what's not assigned out, right? There's close to 2,000 bodies that were not assigned to in-state schools, right? And then there we go to the priority of, okay, the next priority is other in-state institutions. We take care of Texas first, and we go down that there. And then those requests are in a separate category because you got to put the schools and colleges in one category because they get priority. And then all the other entities fall second into another category of demand. And we show it once again, you just take it off the inventory list and continue to decrease that surplus until you've met everything in the state of Texas. And at that point, what's left behind, we can say this is once again a recommendation, the larger institutes that take the most bodies, that take care of others, we can always ask them to keep 5 to 10% of surplus on hand in case one of the Texas institutions, states or colleges, all of a sudden needs a few more. And then everything else that's left behind is allowed, the will body programs are allowed to send out of state. Once again, same priority, states and colleges first on out of state before they move into other entities.
And the non-educational programs are the great unknown, and they're the largest users of the unembalmed or the lightly embalmed. And as you can see, the growth is not in the educational programs. That's a fairly fixed number. It's the non-educational programs is where the tremendous growth. That number is almost doubled in the last 6 years. Educational programs is rather static.
Well, that's what we're going to determine, Dr. Hubbard, is there will be an email that you will send a request in from the non-traditional sites, the educational institutions. And that's what we're going to have to help to determine the needs of the other in-state
Right.
entities that are listed by statute now, right? So they will be asked
Right.
to send in. They can send anytime they want. They can send in once a week, they can send in every month. But once they've sent their request in, then once again, we go back to this matrix to be able to see what's there for Texas surplus and what can be moved to these in-state institutions or entities. And then that will help determine what's left for out-of-state transfers. It will take a little time and effort to be able to figure out those numbers, because we've never really done a full understanding of how many of these entities order from NATO's and how many order from will body programs. Obviously, the four major will body programs can say, hey, 20% of our things have gone to non-educational institutions or whatever the number may be. Yes, Dr. Gilbert.
So two things that's a great point. And I think that in the registration process, which is going back to last discussion, if a facility needs to list where they intend to get their donors from, because that will help us in the projection of where the needs need to come from. Because if a facility says, hey, we're going to go with a NATO, then that number shouldn't affect what we're considering here. If that makes sense. So that's one consideration. The other one is, Ms. Kemp, as we're building the website, effectively, I'm sure somebody smarter than me could make it so that when we assign a TFSC tag number, I don't know how all that's going to work yet, but if we did it our way, the SAB way, once that's assigned to a cadaver, there could be a way for the will body program, once that's assigned to a use, that could be changed as a status or something in that, on that TFSC number, and it could be tracked along that way. So I think not relevant today. We've got to do something different now, but once the website or app is put together, that may be something that can be a real-time change as a cadaver is taken in and then it's assigned to a use. That would help us have a better real-time examination if the will body programs are to update those on an ongoing way.
I think that's the ultimate goal with our website, is to get where everything can be updated real time, so we're not having to do the quarterly reports.
Yeah. But for now, that we've got to do it this way, and this is a good plan, I think. So
I did want to, because I know it's kind of been briefly mentioned. I know during the stakeholder meeting this morning, it was discussed how, again, like these anatomical facilities or physicians, like theirs are usually where it is the unembalmed, and it might be within a week or 2 weeks. And so that's going back, that's where we had talked about where if they can't give their projected numbers of what they would need from like January to March 3rd, wait, what were the dates? May,
Quarter.
so,
Whatever you
quarterly,
want to add.
then they get the 30-day, but if they don't have that 30-day and those bodies are already committed elsewhere, then they're out of luck, kind of thing. The other thing is to free up the will body programs that they don't have, because again, I think the physicians' anatomical facilities need the unembalmed. So if the schools only have embalmed on hand, they're not gonna be required to produce something they don't have. So then, that's when we're like that. We as a commission, we wouldn't hold them liable for not meeting the need in Texas, but if they didn't have it at the time of the request, and
Yeah.
that would free up elsewhere.
And I think we're going to learn a lot this first year from all the non-educational institutions that request bodies, because like you said, they're mostly going to request unembalmed. And as we determine that need through the next 12 months, we will then be able to reset any numbers the next go around to be able to say, okay, look, while we had 500 requests for unembalmed bodies this year, we need to take that into consideration going through the next fiscal year, in essence, to be able to possibly say, can some of these organizations hold on to a small percentage and not embalm them because we see a demand? But that's something that we can't determine until we get to that point.
The other thing I wanted to mention.
Can I raise a question that you may throw a rock at me and I understand, but we are allowing NATOs to work with certain exemptions, but we still have priorities in the state of Texas. Are you going to lean on the NATOs to help supply the priorities of the state if our educational institutions cannot at the same price structure our educational institutions charge?
That's a question I haven't even thought of yet. I would have to look at our statute on that part. 'Cause really, they're not even required to help us meet the priority.
Why not?
Because by statute, they're exempt from us being allowed to redistribute or distribute bodies they have. And it's the priority statute applies to the commission. So this is the other thing I was about to get into was I've read the statutes. I don't see where the will body programs have the authority to redistribute or distribute bodies donated directly to them. I think it has to get commission authority. So that's where I was wondering, where I've been thinking of how all the requests need to come directly to the commission, but the commission could assign will body programs as commission representatives to kind of talk through informally so that the formal transfer request comes to the commission, but the applicant or the transfer requester could say that they've been informally talking with the will body program, and then we coordinate that and keep that open line between the commission and the will body programs. So that may also play into effect of how certain things are.
So the onus of supplying the needs of the entire state are on the education-based will body programs, and the NATOs aren't expected to contribute at all.
You can, the statute is quoted up above, it's that 691.030, 691.029. That's all I can say.
Yeah, so if I
Let them
may,
pay their fair price, Sarah.
if I may, John, I think your point's well taken. None of us understand why it was written this way. I don't think we can change it. I am interested, without going down the rabbit trail, since the TFSC is not going to be able to interact except in an educational way with the legislators, at some point we're going to have to develop a plan that gets the things that may need to be changed in statute changed. But the TFSC, as I understand, can't lobby the state for this. So we're going to need a plan. That's a different issue that we'll have to fight another day. And I'm ready to fight those issues. But what we're currently doing is we're establishing whether we have a plan to get these numbers certified in the state. And I'd like us to stay on track with that so that we can get this answer done, get the commission to vote, and get some of this stuff off the table personally.
Can I just make one side comment just to make sure? We are directed by Senate Bill 2040 to provide legislative recommendations of any changes that need to be made.
Perfect.
To the implementation bill. So I know
Sign me up.
Chair Tips and I have already been in conversation of that we need to start making a list of what those would entail. So
Sign me up. I'm on your team.
but going back, Dr. Lee.
Yeah, thank you, Dr. Hubbard, Dr. Gilbert. Going back to this work group's goal to determine the needs. We've talked about supply and how that supply is going to be updated quarterly. And obviously in each of these spreadsheets, there'll be subcategories of, those kind of things. And also what's been taken off the inventory list because it's going to go to this school because we know this school always requests 100 on this particular date. Now, if I can switch to demand, as in how does someone ask, your organization, State Anatomical Board, for a long time has done it very elegantly to meet all the needs. You have the requests, you have the relationships. We just need to show that to the commission that that's structured, that, hey, A&M needs 29, this group needs that. We need to just have those on there. So having a simple spreadsheet, once again, of historically, this is what the organizations have requested. This is what the slope has been. They tend to stay flat or they go up a little bit because they're a growing organization. I was at University of Texas Health Science Center in Tyler, and they take 40 students right now, but they're going to increase, I'm sure, with years, and they will ask for more things as they go along. So having just that historical data is, I think, important, and then we will add to it the current data to show what their demands are. The new demand spreadsheet, if you want to look at it that way, is the new entities that have been put on there by statute. We have to provide them an opportunity to request. And so the question now is if this entity, that's one of the newer entities, comes on board and says, I need 30 unembalmed cadavers for next month, or they give you the 60-day or 30-day, we need to decide what day, how many days in advance. So first, let me ask you, how many days in advance should that request be put in where they should be given a priority before anything's sent out of state? Is it 30 days or 60 days?
That's, I think, what we had kind of talked most, because when we talked at the stakeholder meeting this morning, we were kind of requiring that maybe not just the will body program submit what their projected need is, but require all authorized entities to give their projected need on those dates, the January 1st to May 1st,
Okay.
So
So quarterly,
September,
all
Right.
entities should be saying, this is what we think we will need in this quarter.
And if there's an unforeseen need that comes up, that'd be the 30-day.
Okay. So the recommendation is, if I understand this correctly from all of us, is quarterly, you need to put your requests in. And if anything comes up that's an unusual need, all of a sudden, it needs a 30-day advance. Now, just because you put that request in doesn't mean you're going to get it, because the will body programs will need to have that supply to be able to take care of the other entities, not the schools and colleges, but the other entities. If you are a school or college that all of a sudden needs something, which is, like we said, hypothetically very unlikely, then there should always be a surplus from the 4 larger institutions that could take care of that possible bump. And I think the stakeholders from the other day said they have no problem with holding back 5 or 10%, because they tend to always have 5 or 10%. It would not be a forced situation upon them for them to have a surplus. Is there any committee statement about that particular work group item?
I
Just
agree with
for-
what you just said.
Just
Ms. Mena, yes, ma'am.
Just for clarity, so if we use specimens for our anatomy lab, I can't order them till September, but I would have to put my anticipated projection in June, if I'm hearing you correctly.
That's correct.
And
The
if
earlier
I
the
need
better.
one more, I would be okay.
Yes, you should put in your request as early as possible, right? But yes, you need to get it in that quarter before, right? Is what we're recommending. And then if there's a unusual need that comes up from a state or college, then you put that request in, and the larger will body programs that tend to have the surpluses will usually keep, and they agreed to this yesterday, if I recall, on the phone, that they usually always have a surplus anyways, and that they wouldn't have an issue keeping 5 or 10% on hand at all times for unusual requests of that sort of embalmed bodies.
And Professor Mena, I know yesterday during the stakeholder meeting, they were talking about for like the medical schools, their enrollment is known way in advance. So if we did a 30, because I know y'all are different, is like if you do give the projection and then we have this 30-day unforeseen, does that provide enough time for you
Yes.
guys with enrollment?
Yes,
Okay.
30 days would help me if I needed to say I'm gonna need one more.
Okay.
Yeah, no, that would help, but I just wanted clarity
Yes.
on, I
Thank-
need to then make that request in June for September.
That's correct. The quarter before that you want to put these requests in. If you put it in earlier, I highly recommend that. So then the will body programs that tend to have the surpluses can plan ahead. So that's one of the recommendations. Yes, ma'am.
Is there a guideline on a response time for these requests of fulfillment or not?
So if the request goes in from an organization that well, quarterly, if you're putting in those
The 30
pre-requests, right?
days, The 30-day.
30 days. I would imagine that the commission would need to answer them pretty quickly, because if they're putting in a quick request,
And we can put
Then-
it in like the form, like the staff form, because we have that right now, I think, for the out-of-state applicants where they say where they need the cadavers by, so that we can make sure we prioritize based on the need of when it will be shipped out, so.
Thank you.
But we can put that role, just that the application has to include that or something like that.
And
So-
just a comment too, is if I don't know, a group says they need 28 cadavers and they end up, their enrollment is actually down, the fact that they only take or end up delivering 25 is not going to be a foul or penalty on them, correct?
correct.
I mean, I think it'd be nice if they would it might be good to have them notify that as soon as a school or
Sure.
college knows that they're not gonna need as many requests, that they let the commission know so that that can be
Right, sure.
redistributed. Okay.
Well, and so in my mind, that's a great point, because at the next quarterly assessment, that there will be an actual total that was assigned or distributed. I think the thing that's going to be challenging and maybe take a bit for the transition to work well is that if the facilities are going to submit no longer to a willed body program, but directly to the commission, then it's going to take a shift in mindset for our folks to not, because we know who's going to request, we know who we're going to provide to. It's going to be, we're going to have to not list those cadavers that we have kind of earmarked for Angelo State or whatever. We're going to have to list those as available until they're approved. I think it's going to make the process a little more clunky, but if that's the way that the commission needs to have it done, we can do that, but it's going to be a little bit of a deviation from the way that things typically work because of those longstanding relationships.
Right, and I think that's where it's probably one of those, like, we start it and we change it as needed, and I think that's where I was thinking, I mean, because if there's been all these conversations informally offline, that takes the bulk off, because everybody kind of knows, hey, we're able to do this. I think that's fine to have that in the forum, be like, where the requester puts, here's who has told us they can provide that way the commission can, I think it would be okay for the will body program to mark, maybe just put in their supply of tentatively who they plan on assigning the bodies to, and committee members, y'all could like any input as needed. That way we kind of see who's maybe the proposed set aside for, and if there seems to be any concern, then the commission can redistribute according to needs. But if it all looks great, then the commission's meeting its statutory authority by authorizing what's been proposed before it. So I don't think that would be a
Okay.
big problem.
So then the intake, the form that we would submit as a will body program would be, here's our intake, here's our projected need, here's those that have been tentatively assigned, and then the surplus. And
Yeah.
quite frankly, if we're projecting into the next quarter, we're going to work on a projected need and we could consider a projected intake. We know within a number of probably 5 or 6 bodies a month, how many we're going to take in, unless we're working on only actuals from behind. So again, that's the hard part, is we know that we're going to get X number per month. And so that will be a discussion point we'll have to work through too. But yeah, this is good. And I think it should give the commissioners a great deal of confidence in saying, yes, we approve. I guess my next question is, once we have these quarterly submissions, and presumably there would be maybe some meeting or discussion, how is the process of approval going to go? Is that something the staff is going to look at the numbers and have the authority from the commission to approve? Or is every one of them going to go to the commission and they have to have an open meeting?
My recommendation is that y'all give your recommendation of what you think would be best, and then we can present that option to the commissioners and let them make the ultimate decision.
My recommendation would be that the staff would be given the authority by the commissioners, once we have the process in place, to make those decisions in consideration of the data.
I have a question, maybe this is a legal question for you, Sarah. Is the commission allowed to let the committee be the commissioner's representative on authorizing and moving, so there's not a lag, or it has to be staff?
By y'all statutory authority, you're very limited as like advisory committee, so.
So, but we don't want to wait quarterly for the commission meetings. We want to be able to approve
Right.
faster, so staff. That's good. That's what I want to know. Okay. So one of the other recommendations, and then we're generally agree upon, is that the commission allow authority to the staff agency personnel to be able to approve these faster and move these faster, versus waiting for the quarterly commission meetings for approvals of transfers.
Yeah. So Aaron, that works. And maybe a half step between what we just said was, Sarah, is it reasonable for the committee to make a recommendation to the staff for consideration on these approvals?
What I might need to do, let me ask Helen that question, because I'm wondering if that's something that we have the commission direct the advisory committee to give recommendations
I
on?
think that's where I was heading with
Yeah,
that. Is
okay.
Can we be the commission's representative to review and give advice? Because if you've never done this before and you've got a group that's been doing this for 80 years, we should be using the wisdom of the people who've been doing this for many, many years versus someone who's just come on board that doesn't even know what embalmed is versus unembalmed.
Well, all of our commissioners know what that is.
Not commissioners, I'm talking about
Oh, okay.
You know, a licensing person or, I know the commissioners not.
And he means no disrespect, Sarah.
Yeah, no, I mean, some of us have been in medicine for many years and others are just learning, things. So let's go back to the very top of this document that has our inputs. Not the very top, right where it says stakeholder discussion on current, right there. We talked about getting projected needs, projected intake and surplus required. And the recommendations on what that surplus should look like and the stakeholders put their input in. We talked about the quarterly requests versus the emergency 30-day requests. So if you scoot down to the part that says whether commissioners should meet, scoot down a little bit more right there. We talked about we'd like the commission to allow the staff to be able to help with the authorization of the distribution and also asking the commission if the advisory committee could help review and give advice to the staff.
And I think if the commissioners decide to involve the committee, what may be good is that we're not having to worry about the publishing and trying to get everybody together to make a form is that staff could send out, here's the report, and they individually give the feedback to staff can report that to the commission with the recommendation.
Also go to a work group. That's
Then
not a
with the
quorum.
work, well, you could,
And if the work
as long
group
as-
has the major will body program or will body people in the past, well, the two will body representatives on the committee.
but do you want just the will body? Cause the
Well,
work
then the
director is
third-
gonna be the anatomical facility.
I know, but the third position is that open position that I can be on that represents the other two. And
Okay.
it's not a quorum. You've got,
Well, as long as you're not, what we would have to do then is for it not to be posted in the Texas Register that whatever y'all's recommendation is, staff sends out to the entire committee to approve
Sure.
and then that goes to me. Okay, okay.
so projected needs should include, and this is something, who you are, where you're located, all the things that would be on your application that's listed with as an authorized entity that's been inspected and approved, right? So all this information would be on there, that you wouldn't be requesting if you're not approved, right?
Well,
So,
if they are approved, I think that's where we had talked about maybe putting in a longer time frame where a 90-day or something, because they have to get approved first before they can request. Move on with the press, I don't know.
I just don't think you can put a request in until you're approved, period.
Okay, so where
Because
we
we
just.
can't have the will body program pull aside 20 bodies and then find out that they're not gonna be
No,
approved.
no, I just know right now, based on yesterday, they were saying the website's open to everybody, whether they're approved or not approved, so
To
would we
apply,
then have
not to
the,
request,
to what?
to apply, but not to request.
For them, it's the same, because I've seen requests from out of state and in-state that aren't necessarily.
But this isn't a
authorized.
statute, this is more of a recommendation by the commission or the committee of, you've got to apply first to be
No, I
approved.
agree, so what I'm saying though is because currently the website is set up to be open to everyone, then we may need to make sure that we limit it then to maybe only authorize to be able to do the application for bodies.
Right, no, to
Okay.
request, you have to be an authorized entity. To
Okay.
apply, you can be whoever you want to be until you get approved. So, as I'm going down this, scooch down to either annual cadaver specimen needs, we've talked about determining the needs on our two Excel spreadsheets or matrices. And then obviously in the request, what's needed, what's going to be used, educational purposes. There are forms that have been used in the past by will body programs. We can look at that form again and make a little bit more specific bullet statements as to what's needed, what's requested, what's going to be done. But I think that's pretty clear from the previous will body program applications on requesting a cadaver. And we will pretty much mimic those same details that are needed if you're requesting a body. And if The only place they can be sent to is an authorized entity, so it'll meet all the inspection needs, which we'll discuss next.
So, I don't know what page you're on at this point, maybe 6.
What's on the screen? Yeah, 6.
Oh, yeah, okay. I guess I'll wait till we get to the bottom. I've got a comment that was brought to my attention.
The rest of these bullet points are supply and demand and who the contact is. These are all, once again, it's in the application process. So all the contact information and everything of the will body programs, NATO or anatomical facilities will be listed already as an authorized entity. So the commission can easily find out who's there, what their all contact information is. The next part of page 6 is projections submitted. We talked about doing this quarterly. And then the feasibility on keeping real-time track of availability of donor cadavers, number, whole body or part and condition. We've talked about it's in inventory. It's been proposed to be used for particular state, college or university, and then down the other entities of priority. So I think we've discussed a lot of this unless someone sees something on the bottom of page 6 there that's on the screen. When the commission does receive a request, who is the request going to be sent to when it's being sent to the will body programs? Is there a priority who it gets sent to first? Is it a geographical priority? Or is it sent to A, B, C, D in that order? Because if all 4 of them get it, and then all 4 say yes, now you've just committed 4 cadavers to one request.
Well, I think that's why it's coming to the commission first to look at who's.
So the commission is gonna decide, I want to use UT Southwestern.
Well, the commission would be like, okay, this need came in, we're sending out an email to all Blue Light programs, here's the need,
Oh, my
please
word.
let us know who can satisfy.
Input on that?
Yeah, that's going to be extremely burdensome. If you're talking about 50 requests in a month, that's 50 back and forth emails and, oh, I'll do it. No, I'll do it. I think the request theoretically could have a line that says, have you already communicated with the will body program? And if so, who is that?
Like, yeah, kind of like how what we were talking about for the quarterly. Okay, and maybe it have not just one, but maybe like a couple that if they, because I think there, in our conversation yesterday, or maybe it was this morning, we were talking about like a case of a catastrophic event where maybe 5 cadavers come from one school, 10 from another. So maybe we have like 2 or 3 options of
So can I
track of.
recommend kind of what Dr. Gilbert
Yeah.
is saying is if I'm an entity that wants to request,
Right.
I go on the website. Usually, I would hope that there's a general paragraph there that says, look at what's the regional will body program closest to you.
Mhm.
Here is the contact information, request from them. If they say no, then send an email to the commission saying the closest will body program to me said no, who would you refer us to? And then the commission would say, we would refer you to this group because we know they're surplus. Or if the commission sees that the first group that was asked for has 100 surplus, why did they say no? And that kind of keeps a little bit of guidelines out there for some organizations to just say no willy-nilly, right? So I think that will provide, instead of 50 emails going out for one cadaver, to all the different groups back and forth, I think that would be very difficult.
Yeah,
So,
no, I like that. That's good. Again, just keep the authorization for, it may just be where, oh my gosh, sorry, I just had a brain fart.
shoot.
Kind of like what we were doing with the quarterly reports where the will body program, it may need to be the will body program after all that submits it saying, we received this request, are we authorized to redistribute to this person? Yeah. I mean, like if they've already talked about it offsite, that's fine, then we can just.
Correct, right. So I think the commission's website should instruct the authorized entity, if you want to apply for a request for a cadaver, here's geographically the regions that these groups cover, and you may request from there. If you have an acceptance, then you deal with that will body program, you go through the process. If you have someone that declines you, you come back to the commission and say, I've been declined by this organization, what should I do next? And then that will help us refer them to the next group and so on and so forth. We'll also allow the commission an understanding why it was declined.
Do we wanna, I'm just thinking, and I don't know, instead of like per request that comes in of who's been granted, maybe by like the end of each week, will by program submits, or do we keep it as it comes in? like, here's the number of requests we got, here's, I don't know how
Well, I
often.
would imagine that, the quarterly, they should update once
Well,
again, if
maybe
that's.
you were talking I thought we were talking outside of quarterly reports. If we're not, then that's.
No,
not
I was
good.
just thinking if an authorized entity calls up UT Southwest and says, we need 5 cadavers and the need is met, it's met, so UT Southwestern will update quarterly what was sent out to all the different entities, but if it can't be met,
Okay, but remember what we were talking about with the quarterly is that they'll put tentative, here's who we're gonna apply, because it's the commission that has to authorize everything.
correct.
So they can add it to that report that they put, but I'm just making sure we're staying consistent with our process.
Yeah, I mean, if an authorized entity that's not a state or college says, we know this quarter we need 20 and that quarter we need 20, then they request just like everybody else does. If something pops up urgently,
Right,
that we need 3 cadavers in 2 weeks, they go to their geographically located will body program or the will body program they've always worked with, request. If they get declined, they come to the commission and say,
okay,
been
but
declined.
that's different than what we were talking about earlier with the 30-day. Cause I thought we were saying any urgent thing would be 30-day and you couldn't do past the 30-day. So
No, I understand. That's
2
what I'm
weeks
saying.
would
So-
be,
well, I'm just saying that the 30-day. Maybe we're saying different things. Dr. Gilbert?
Yeah, two comments. I think that if a person whose facility is requesting cadavers and they submit something and say, I need 5, but I don't know where to get them and I don't have a connection. I think that the commission should send a list of all the will body programs out that might be able to meet that and go from there. It's the same thing that the SAB currently does if they don't already have a connection. The other question, and I'm sure this one is gonna maybe be a little more problematic, but what we're doing is we're developing myriads of strains of contact between the commission and all of these users. If a facility already has contacted a will body program and has a plan, would there ever be a time that the will body program could gather the information on behalf of the facility and submit that to the commission on that facility's behalf to streamline the numbers of input that's coming into the commission?
I think if it's the application process, it has to be the actual entity, but if it's transfer request, I think that's what we were talking about earlier. The will body program being the one that says here's supply, demand, tentative assignments, and they could, because if we're only talking about authorized users, and so if the will body program submits all of that information and then the commission just was like, yeah, because we know that based on everything else that's been provided, all the schools and colleges needs have been met. So I think that would be fine.
Okay, so really what we're talking about then is that the commission's responsible for approving the transfer of a body from a will body program to a facility. Is that correct?
Yes, sir.
So why then would it matter where the request came from? In other words, what we currently do is somebody contacts the will body program and says, I need 5 bodies for this training, whatever. And then we submit, because the donors are in our custody, we submit the request to currently the SAB to, well, I don't know what we're doing now, but what we will do is submit a transfer request to get approval from the commission to send it to the facility. So I guess that's what I'm struggling with, is that we seem like we're creating an additional step that you're approving the facility to receive the body, but we've already theoretically inspected them. If they're not approved, they're not going to get it. So why couldn't it be requested through the will body program? The transfer is then done between the will body program and the commission. Once it's approved, it goes to the approved facility.
Dr.
And the
Gilbert?
will body programs will be submitting all their transfer requests for approval to the commission.
Right.
Can I make a request or give a thought on that?
Sure.
The will body programs will be taking 100% of the bodies that would be supplied to the state of Texas. NATO's are different, right?
Right,
But-
those are completely
right,
out.
so- The will body programs are the backbone of the state to be able to supply bodies to everybody in this state or out of state too. The will body program should be the commission's representative.
Agreed.
right? So now I, as an anatomical facility, send Dr. Gilbert a request. Dr. Gilbert can fulfill the request. He doesn't need to ask the commission, may I send this transfer? The transfer is between a commission's representative, the will body program, and the entity. Everybody's approved in this chain, right? And everybody follows the same rules and laws.
Agree.
What I'm saying is quarterly, these will body programs that are the commission's representative will now update their data into the commission to say, here's what we have, here's what we've given, here's where they've gone, right? If I'm an anatomical facility, I go to the commission's website, it says, here are the will body programs. They're the backbones of Texas. Request from wherever you want, right? I go through the process. If I get declined, I think it should state in there, if you've been declined, go to the next one and continue. But if you get declined by all of them, then please send an email to the commission so we know where the declines are, so we can figure out what that need has been that may have not been met. But that will take time to build that data, right? But the other thing that we'd like to get is anybody who's not a state or college that's going to ask the will body programs who are providing 100% of the bodies. If you're asking, you've never asked before, where have you received your bodies before? How many bodies have you taken in the last year to 3 years? And one of the recommendations is to get historical data on all these entities, right? So we want to build a database for the state of Texas that says, wow, organization A just requested a body, and they've been doing this for 10 years from UT Southwestern. Wonderful, we have that data. But organization B that's never requested ever, all of a sudden requested 100. We want to know why. We want to know where, what this demand has come out of nowhere for, right? Because if the onus is on the will body programs, well, they should have some ability to say, hold on a second. You know, if you have a huge increase all of a sudden, we need to know why and a stated reason, because we're not just going to say, here's the bodies because we're forced by the state of Texas. There has to be some guidelines in there, right? So one of the things was if there's an increase of 10% or more in a request that traditionally is different than before, then there should be a reason given. So then the commission has the opportunity to look and say, there's a reason given, the reason is appropriate, you know, let's fulfill. But that's what I would recommend is that the will body programs are the commission's representative. They make the decisions, they do the transfers. Quarterly, they update. If there's a decline, that entity that's approved may either call the commission and say, hey, I got declined, or go down the list of authorized will body programs that will support you.
Okay, I'm gonna interject real quick. Trying both of y'all's comments. So 691.029 does say the commission may receive, distribute, and transfer a body or anatomical specimen from inside or outside the state. 691.030 does say the commissioner or the commission representative, but it doesn't define commission's representative. So what I think y'all would need to do is recommend to the commission that they appoint will body programs as the commission's representative to do the procedure you just explained. And then I mean, again, it's gonna be the commission's ultimate decision.
Absolutely, no, I mean,
So-
I don't, that's why I think this would resolve a lot of problem for the will body programs, that you're going to be taking all the bodies, you're the ones that have the onus to supply all the bodies, that you should have the commission's authority as a representative will be the recommendation from the committee.
So if y'all and Dr. Gilbert, if you don't mind doing that bullet point of what you kind of just described, and I know it's the current process, but it'll help me just to have it in writing, and then put recommends, you know, that the will body programs for that purpose be appointed as the commission representative.
Okay, yes, ma'am.
Thank you.
Okay, going off page 6 on to page 7 here. When a new facility is approved, Clint, if you'll scroll down, please. This is saying that if a new facility is approved, indicate kind of historical data, right? We would like to know the last 3 years of where you've been receiving your bodies. If you don't have that historical data because you're brand new, we want to know why you've requested 100 all of a sudden. You know, large numbers that can really affect the supply and demand of the inventory controlled by the will body program. So once that's inputted, if the will body program can take care of that, wonderful. If they can't, then I think that entity can ask the commission, hey, this is what I request. And then it's up to the commission or their staff to either say, I'm sorry, we can't take care of 100 bodies all of a sudden requested by you, or let's see what the surplus looks like and have an opportunity to discuss. So this gives both groups a pathway to discussion and understanding why or where or who this organization is that's new that's popped up and is asking for demand on the supply. The other recommendation is that if you've received your supply elsewhere from a non-will body program, that they state their last 3 years of where they've received their bodies, which organizations supplied them and how many, just to create historical data to understand where this group is. Because if they've taken 400 bodies from NATO's last year and all of a sudden they want 0 from the NATO's, they want 400 from the universities, we would need to understand why that changed and what's happening to allow the will body programs to say, this is not what's happened historically, but we understand there's been a change in approved entities, so we can kind of adjust, but it's got to ease some of that burden off the will body programs. And this is all just building historical data so we can go forward in case the supply and demand needs to be shifted around any. Any comments on that?
I don't have any issues with it. I can predict what's going to happen, that this is going to happen simply because the NATO's charge, excuse my language, an arm and a leg, a trunk and a head for their specimens, and the educational will body programs don't.
Well,
They're going
I
to turn
think
to the will body programs for their specimens first.
I understand, but there are other details involved with some of these things.
Yeah.
Let's not, I don't have a crystal ball, neither do you, but let's see how it goes. That's why we're going to have this rolling data coming in quarterly for us to be able to determine. And as we go along, we'll get smarter and understand it better as the committee and the commission.
I also think it's good statistical data
Yes,
to build a history on.
absolutely. And I think the recommendation should be to go back 3 years from any entity. If you don't have 3 years of history, go back as far as you can. If you're brand new, submit as to why you're requesting what you're requesting. If we scoot down to advisory work group proposal for determining needs, a lot of this is repeat. We've talked about getting historical data from the Texas colleges and schools, and the will body programs and the state anatomical board have a beautiful amount of data on this that we will add into the historical data. Same thing, it's all about the database and how to get all the historical information. And we had just picked random times, January 1st, May 1st, those are just written in there as kind of placeholders, but we've talked about quarterly. And if we go down to page 8, it's the 2 graphs that we showed, the 2 tables, excuse me, of the amount of data we have currently. And we would like that next table down below to be filled by other authorized entities that will request. So we'll be able to kind of start getting that historical data built up to help us determine supply and demand.
Could I ask that maybe for both charts, we add, kind of like what we discussed earlier, unembalmed versus embalmed, and then whole bodies compared to parts of bodies? And it's, if they don't have it, they can put NA
Sure.
for that year.
No, I
but
think
just
that's
to
great. This
check.
was a very general
Okay.
statement just to show placeholders. This is not the actual wording we'll use, but
Okay.
one of the things I recommend is that the spreadsheet have the ability to add all sorts of columns as we go along, right? It's not, these are the 4 columns only.
Got it.
It's an open document to be able to add data that we think is important.
Yeah, so in rule form, perhaps this would be described as basically the commission would collect ongoing data of cadaver donation and use in Texas or something like that. And then the spreadsheet can develop and morph as it needs to.
Correct.
Okay.
If we can scoot down, Clint, to the next page. So out-of-state schools and colleges, this has been a large issue for the stakeholders. The willed body programs that have the onus of getting all the bodies to the state's schools and entities here in Texas also have a large supply that they have committed to other organizations outside of the state of Texas. It's the recommendation that obviously following the supply and demand charts that we have that the state of Texas is taking care of and other entities in the state of Texas, as we will determine their needs as we go forward, then the surplus is allowed to move to same priorities, state and colleges out of state, following the same exact rules that we have here in Texas. You'll see the acronym OSTR out-of-state transfer request form. Not that that is the actual wording, but that's just kind of a placeholder to show that an out-of-state organization would have to do the same process. You apply through the application process, you get approved, and then the commission's representative, if that's what the commission will allow us to do, which is the Will Body Program, will then take over. And just like anything else the Will Body Program does, they have to make sure that the entity that's receiving the cadaver follows all the rules of the state of Texas, can pass the inspection process that we will discuss soon, and meets all the rules and regulations of Texas. And the Will Body Program is the chain of custody of that body that's being, in essence, lent out to the other state or college. I'll stop there for a second. Dr. Gilbert, was there other input on that statement there?
You're on mute.
You're on mute, buddy.
Sorry, my mistake. I was preoccupied on something. My brain went somewhere else. So no, I don't think I can answer your question.
Okay. Well, once we have determined their surplus and it can be sent out, like I said, the Will Body Programs, the onus is on them to make sure it's going to an entity that follows all state regulations here in Texas, even though they're in Oklahoma or wherever.
Yeah.
And then there's the discussion of long-term chain of custody versus short-term, meaning if you're giving that cadaver or those 25 cadavers to Oklahoma for a years-long program with their medical school, dental school, whatever school, that's in essence a long-term chain of custody, that all the chain of custody paperwork that you would have here in the state of Texas be followed too. Same exact SOPs that need to be checked, everything that the application process and the inspection process says that you need to have. It is on the Will Body Program of the state of Texas to make sure those requirements are checked off and done on a long term. The other recommendation was on a short term, meaning the state of Texas Will Body Program wants to send a cadaver to Oklahoma for a weekend bioskills lab, that the chain of custody, once again, is under that Will Body Program to the point of they have to send a representative with that body, stays with the body because it's at an unusual anatomical facility like a surgery center that is not made for overnight storage, that is not made for a lot of these things that won't meet our inspection criteria. But if the chain of custody is there and you're there with it, and then you bring it back, then that continues to be under the state of Texas kind of chain of custody. Whatever costs are borne from that, that's the Will Bodies Program to deal with the other entity. If you're going to charge them for that cost, that's up to you. If you want to supply that and it meets all the rules and regulations of Texas, that's up to you, the Will Body Program. And any costs that are brought about needs to be taken care of with the Will Body Program and that authorized entity that you've set up.
Yeah, I think that can make sense. I would say though that the Will Body Program that's providing that, that they would not be forced to provide that if they don't have the man-woman power to travel, stay in Oklahoma for 2 days and then come back. We would need to be able to have we can provide the specimen, but we can't do it in that format. Therefore, we can't meet that need. Is that a reasonable response in the Will Body Program?
I think that's where we're going with it, is that every single surgery center and mall that has a aesthetic center just can't willy-nilly request that, if you as a Will Body Program cannot send an authorized personnel with it, then I'm sorry, we cannot meet your need. And that allows you the opportunity to say, no, thank you.
Yeah.
Yes,
Okay.
Dr. Hubbard.
Absolutely. If you're not able or willing to meet those requirements, you have no business getting in that business.
Right. So the Will Body Program, if we move forward with the commission, allowing you to be the commission's representative, has the authority to say, this is the only way I can get the specimens to you. You have to pay for our costs to have that person there. If you don't have that personnel, then you don't have to provide them because you don't feel that that's an entity that you can take care of. If it's a state or college, you've developed that relationship. They met all the needs. They follow the exact same criteria. You supplied the long-term body. They have the chain of custody there, though it's still on you as the Will Body from the state of Texas, that if something happens to that cadaver, ends up on national news, or they leave it sitting on the parking lot, that is on the Texas Tech or A&M or UT Southwestern, that you sent that body there. It is under your responsibility. So the state of Texas will be talking to you, UT Southwestern or Texas Tech. not Bob's College in Oklahoma.
Well, I
We
do
have an obligation to make sure that whoever has receipt of our bodies are taken care of appropriately. If we can't meet that need, we can't send the bodies or the specimens out.
Right, so the question is, whose responsibility is if something goes wrong in Oklahoma and let's say Texas Tech sent that body there? Because the state of Texas can't go to Oklahoma and try to
Right.
go after someone in Oklahoma. Yes, Dr. Bill.
Ultimately, it's that program's responsibility. The body is donated to the state of Texas through that program.
Correct.
The buck stops here.
Dr. Gilbert?
Well, yes, I agree. However, wasn't that the point of the contract, whatever process the TFSC approved, was to try to create some connection between, let's say in our case, Las Cruces and the state of Texas. I'm not arguing that our will body program is responsible for where we send them and what happens, but I guess the issue here is that the state of Texas can't sue the
Right.
The other entity. So yes, we're responsible, but
I think the application for the out-of-state organization is so the commission knows and has record of these are approved entities through their commission's representative, the Will Body Program.
May I interject?
Yes, ma'am.
So, the contract process, you have to remember, was a temporary solution until the committee adopted rules. And so as the committee, if it's y'all's recommendation that these will body programs are to be held completely liable for any misconduct by the out-of-state facility, and that their registration or authorization could be suspended, revoked, probated because of that misconduct, that's up to you as the committee to, this is your chance to figure out what all liability you want the in-state programs to have for out-of-state misconduct. And I
So what-
believe for the NATOs, or at least when I've talked with a couple of the NATOs that do out-of-state, in their mind, the chain of custody is always with the NATO, so that if something happens with the client or whatnot, they're held responsible. But I could be wrong.
I
I
know
think
that
that's not
there's,
for particular.
we write a contract with the NATO saying that when we receive their NATO specimen, we're liable for everything we do.
Oh,
to it.
y'all, okay.
Yes,
okay,
absolutely. I mean, they will come after us and sue us if we do something that gets them in trouble,
Okay,
right?
okay.
And what I'm saying is, what I'm suggesting, or my opinion is, if the Will Body Program wants to take the responsibility of sending something to Oklahoma, then you are assuming the responsibility and that chain of custody, though you're in essence leasing that body out. I hate to say that. If they do something wrong, you may go after that university through your own contract and your own terms and agreements, but the state of Texas can come after you in essence, right? So that's what the NATOs do to anatomical facilities is your own state's gonna go after you, we're gonna go after you, everybody's gonna go after you, because someone else may go after us for giving you the body. But the whole concept being is, look, you did all the right things, and this is like the standard of practice in medicine. I know that patient expired in the operating room, but we did every single thing to standard of care. And so you still won't get in trouble with a lawsuit. You may get sued, but you won't be guilty of it, right? So following all the rules, setting all the standards, and checking all the boxes is what's important here to make sure that they've been told, just like the consent form, you've been told that this could be used, photography could be done, all these things. Same thing with the contract Will Body Program setting up at the out-of-state.
Yeah, all right, so to restate, if we sent to an out-of-state facility, they do something wrong, state of Texas can come after us because we were the ones that said it was okay to send it there and we sent it. But ultimately, then our university could go after that facility in whatever way that works. Is that right?
Especially, yeah, and I think especially too, if the commission is designating the Will Body Program as the commission representative to send the bodies out of state, I mean, that's a high level of authority, so I think it should be a strict.
No, but yeah, but here's, yes, I agree with you. But I also would say that what we're suggesting is that the commission is approving the transfer of that body because the bodies are really under the custody of the commission. We're your representative. We're going to go inspect, but the commission is approving the transfer based on our, I guess what we're saying, our approval of that facility. Is that right?
Yes.
And if that's the way that needs to work, I think that makes sense. So,
But my only question is, now that we're talking about that too, and I think I put it in there, I don't know, like, I don't think we have the authority to inspect the out of state or require an inspection out of state. So I don't know how that would.
That's what the onus on the will body program is.
yeah, that's where
Up
we
to
would
them.
come in to say, we're gonna, because what would happen is, Jason, anytime we send it, well, we only have one place we send out of state. And he has made trips over there periodically to make sure that when those are delivered, he's inspecting the facility. If he gets there and it's not appropriate, then he's not gonna deliver, basically.
And
So,
I think that would need to be in the capacity as the will body program, not as a commission representative. Okay. Okay, just wanted to make that clarification.
Yeah. okay, yeah, just want to understand.
Clint, if you'll roll down that, the rest on page 9 is exactly what we we're just talking about. And then page 10 there, same concept. We had talked about a short term versus long term, but that's up to the will body programs as to your decision on, can you have someone there to cover chain of custody? Do you feel comfortable? It's the responsibilities on you as an authorized entity, as a will body program as to where you're sending this, right? So places that aren't traditionally built for, you know, if it's not a medical school, dental school, but it's a surgery center or a ballroom in Oklahoma, once again, it's on the will body program to make sure whatever entity is getting it can pass all the inspection rules.
I mean, do y'all, I think it was proposed to you, are y'all wanting to recommend limiting it to just schools and universities out of state?
That's my recommendation, but I don't own a will body program. I would love it not to go to these random places. I would love for it to only go to the same higher entities, educational entities as Texas. Dr. Gilbert, anything against that or for that?
No, I think that would be my preference as well. I think we're going to have some folks in some will body programs do a lot of, or haven't traditionally done a lot of provision to other entities that are doing bioskills labs. That's not the challenge that I think we have there, is that those are typically, my understanding is that they're typically segments of a cadaver, not an entire full body. And so that's where the things get a little bit more muddy. So there's a tracking issue there now that the parts have been separated from the body. I think the simplest thing to do is make sure that we're covering the needs of medical schools and health professions, chiropractic at universities first, in the same priority that it's listed in our statute to meet our needs in Texas. So I think that would be the justification for that, is that we're going to follow it in the same priority needs that we have in our statute in Texas. So that's one consideration.
I agree with that.
One last thing that was mentioned on page 9, one level up. I think there was a list on that last bullet: out-of-state entities may only be higher at level education institutes, medical, dental, PT, forensics programs. I think whatever we do, we need to make sure that it's inclusive of the same ones that we might have in Texas. So chiropractic is not on there. If you put PT and you don't list OT, what does that mean? So I think we should probably pick either a more broad set of categories, medical, health science related programs, something that's more inclusive. Otherwise, we're going to pigeonhole ourselves.
Robert, how are you today?
Doing
Can we-
okay. How are you?
Can we,
Good.
Dr. Hubbard, I
just
think you're on.
wanted to know it.
Thank you.
I think we can generally address that by just referencing the statute that for out of state, you just follow the same priority in 691.030 A, B,
Yeah,
whatever
I
that
think
is.
that's the best thing. I mean, it's already clearly defined in Texas statute. Let's just say refer to that statute.
Yeah.
I had a follow-up question based on, Dr. Gilbert's, one of his statements. What's the committee's, thoughts on whether limiting out-of-state transfers to whole bodies rather than bodies and parts? Whether it be regardless of.
My thought is, whether it's a part or the whole, you treat it the same. I mean, if you're gonna send a shoulder to so-and-so, you follow the exact same rules and recommendations as if it was a whole body.
I guess my question is, do y'all want to even allow parts of bodies to be sent out of state, or do you want to keep it as, if it goes out of state, it has to be a whole body?
No, I would say whatever you're doing in Texas, you can do out of state. So if you're sending parts in Texas, you should be able to send parts. Because what if one of the dental schools just wants cadaver cephalises, right?
Okay.
And all of a sudden we've said, no, it's gotta be the whole body. And they don't, their tables can't even accept the whole body, right? So I would say whatever you're doing in Texas, you follow the same rules. Or same recommendations. So that was the third work group, and we're gonna come back to the inspections. It is 12:15 here. I was gonna recommend we take a 30-minute lunch break. And come back at about 12:50. That gives us a little time to close up here and come back and start the last work group at 12:50. And try to finish that up by 2:00. 10 minutes to 1 is what Ms. Long says.
2 o'clock today, sir?
Yeah, I know, right? That's a good one. That's Ms. Kim's problem. She's the one that takes stakeholder meetings 3 days. Okay, so let's adjourn for about 30 minutes. We'll come back, let's say 12:45. We'll come back at 12:45 and knock out the last work group and then go on to other agenda items and then set up for next meeting. So we will adjourn now. Thank you. Okay, thank you, Clint. We are going to reconvene our State Advisory, Anatomical Advisory Committee meeting. Quickly checking that we have a quorum. I see Professor Mena. I see Dr. Gilbert. If you'll just show us your pretty face, Dr. Gilbert. I have Mrs. Long to my right, and myself. Carrie, are you there, sir? So we'll need to wait for Dr. Gilbert. Are you almost back as we need you for a quorum? Okay, even if you can jump on the phone too. 1 second. Can I ask you a question even though we're open?
I mean, we don't have a violent now, so.
Right, yeah. Talk about anything else.
We muted.
Yeah, I can mute it.
$9. Okay, sorry about that.
That's all right. Okay, we would like to reconvene our State Anatomical Advisory Committee meeting. We have a quorum, Ms. Mena, Carrie, Julie, and myself, so we have 4. And we may proceed now with our discussion of the inspection process outline that the work group of Professor Mena, Cody Lepaski, and Julie Long were on. If we can share that document on the screen for our participants.
So, Clint, that was the one that was sent around 9:30, I believe, in that email. Let me pull it up, hang on.
That's not the input, right?
Right.
Um,
There, anatomical inspections.
Right here?
Yeah. Yep.
yes.
Okay, I am going to give the floor to Julie and Mary to discuss their recommendations, as Cody is not on the conference call right now.
I thought I saw his name.
Oh, do we need any, I'm so sorry, did you already establish?
I did establish a
I'm
quorum,
so
yes,
sorry.
I've seen everybody's visual faces, yes, ma'am.
Mr. Lepaski was called to another meeting. Just so you know.
Okay.
Oh, darn. Okay.
Well, we're gonna give the floor to the 2 of you guys to discuss your work group's recommendations. As I was told, you all received an A+ for your work versus the other groups. At least Sarah told me that y'all's was very complete and very nicely done.
Thank you.
So,
Yeah, well, I'll just give a quick summary and then Ms. Manna, if you wanted to jump in or add to, feel free. I think collectively, like what Dr. Gilbert was saying, whenever he was introducing his summary, is that we did not want to reinvent the wheel. Rather, our intent was to provide clarity. So we tried to the best of our knowledge to cite or at least mention some guidance on referring to requirements within state, federal, other regulatory governing, institutions such as OSHA, those types of things. So that then it's not one's opinion or a group's definition. It's really just following the guidance of things that are already written. And then it's not in bold, but on that first page, Ms. Menez, what you were, I think we're referring to on the 6th bullet about facilities undergoing significant alterations.
Mhm.
It was my recommendation that we consider referencing Texas Administrative Code rule. That is specifically for healthcare facilities. However, I think that there's some good verbiage that could be utilized, including some OSHA guidelines as far as significant alterations that would alter occupancy code, fire safety, those types of things. Aside from trying to find those definitions within other regulatory opportunities, I don't have any other feedback on what significant alteration would be other than my own
Real
opinion.
quick, and I know you emailed it to me, but do you remember what title that rule is under? On the
25.
It was under 25, okay.
Mhm.
And it was it anatomical board rule or? was
No, it's
The Department of State?
it's within the healthcare facility side of things
Thank you.
undergoing
Okay, I found it.
construction.
Okay, thank you.
Yes. And so then paired with that, it was a recommendation that these facilities that are meeting said significant alterations consult with the commission prior to the start of construction and then request for a re-inspection within 30 days of the proposed completion of the alterations.
Yes, I think that was just when we were talking about that. And I think Dr. Gilbert mentioned something that I think that some of this is repetitious in different areas. But I think it also in each section helps provide a little bit more clarity.
Yeah, agreed. And to your point, would want to make sure that if we're not citing code, that we are clear with how we're using verbiage, terms, etc. Because to your point, we do talk about final disposition, cremation, those types of things would be some duplicated efforts and hours as it was in the application process.
And I think we spend a lot of time going back and having a reference.
Yes. Yes, which I personally think is helpful.
Mhm.
So I have one question about significant alterations. I know you're looking at health facility type definitions. Would it be important to let people know that our authorized entities, that if they're changing something that affects ventilation, if you've doubled the size of a room, but you don't have the same intake or outtake, if doors are moved, the new security measures need to be put in place, that the next door added or the next room added has security measures. That if those things occur, that they at least let the commission know that these alterations are being made, and let the commission decide if it's a significant versus insignificant. So I don't know if that's something that's necessary or.
I'm reading this rule that she's got, so one of it does say, like any alteration, modification, replacement, or installation of a new building equipment such as mechanical, electrical, emergency power equipment, energy utility management, which I think would cover the HVAC, conveying systems, plumbing, fire protection, or other equipment with the primary function of building service that affects life safety, infection control, functional operation, or the health, safety, welfare of patients and staff, which we would say of the, maybe like the, not.
Students, the doctor, the
Right,
clients.
right. And so to me, if they're doing anything you just described and it could affect some of that, then that would require.
I think that's excellent with the things you just stated from it, that
Mm-hmm.
covers a lot of those things.
I was just lazy and didn't.
So I was like, you need to
So lovely.
repeat, if you could just reference.
Sarah,
Check.
on there, I don't know if, I'm sorry, I had to turn my volume up. I couldn't hear you that well, but I don't remember, and you may have said it and I didn't hear it, but I don't think I made this up. I think I also remember reading somewhere that if there were any alterations into the entrance of the facility, because I know that's also key.
I think that would affect fire and control of crowd if there is a fire, if there's alterations to entrances. Because I know when we had our facility approved, the fire department has to come and approve every exit, how far it is, emergency exit lighting, all those kind of things. So that should fall under that TAC rule of you're messing with fire inspection.
I'm thinking
Fire exits.
more of privacy.
Yeah, I think the issue might also be line of sight to cadaver
Yes.
donors and that sort of.
Yes, that's what I'm thinking.
Right, which probably wouldn't be in that.
Yeah, and we could add that as that in addition to this, if there's anything, okay, so like affecting, hold on.
It is stated
there's
further down.
on the rule that y'all did.
Yes.
Mhm.
Okay, hang on. let
Yes,
me-
ma'am. Because when I'm reading this, that bullet about Texas Administrative Code 131, I'm thinking to myself that we probably, well, it is stated further down. I'm just
It's
thinking,
on
do we
page
have to put
3.
it somewhere else?
Hang on one second.
Page 3 and recommendations for standards of facilities on video surveillance, public welfare and accessibility, right there.
Right, so it could be a comment, that significant alterations would include modification of accessibility, impacting public visibility, security, etc. All things that,
Right, okay, I got that.
The dignity and respect.
yeah, that fall under the dignity and respect policy or policies.
Well, and then also kind of like what your inspection requirements are. So if it's anything that changes that.
Right.
Then yes. Okay, sounds good. Good memory, Professor Minna.
Let me see here. Did anyone, 2, 3, 4, 5, and I don't know if everyone's had an opportunity to review this, but on that first page, does anyone have any comments, suggestions, or recommendations on that very first page? And I think the other thing, that one of the main things also is we changed the title from standards of for facilities to recommendation for inspection of facilities. Does anyone have any comments, questions, or suggestions on any edits that were made to the bullets on that first page?
My only question from a staffing perspective, and y'all have to help me remember, Professor Minna and Chair Tips, do we currently have a time frame in which our inspections for our funeral establishments have to be conducted? Is it like 60 days?
Yes.
Okay, just as long as we're keeping consistent. Okay, that's all.
I don't
So-
have any,
But it has to be before the expiration date.
What about for new facilities though?
We can't open it until we can inspect it, and that's at your leisure.
But, okay, so the new inspection procedure, it's not a 60-day requirement, it's just if it's like the every 3-year
It
inspection.
could take 3 months, it could take 6 months.
Okay, so I think that may be the only thing I have, maybe we could clarify that if it's for an initial authorization or registration, that we remove the 60-day requirement just to make consistent with what we're doing for funeral establishments. But put in there, like, we'll exercise, maybe put in there a thing of that if there is classes or courses dependent on the opening, then that will be taken into consideration for the inspection timeframe.
So you're referring to
It's
that
the
they will
fourth.
be inspected within 60 days of the
Mhm.
receipt of the request?
Mhm.
Okay.
Yeah, I think that's the fourth bullet, right?
Or, yeah, so attempted to, for all initial,
Mhm.
and then that there would be some type of a prioritization.
Right, I mean, it's like we don't wanna
Sure.
prevent courses from happening or like if it's for a school or college. I just don't, again, cause our inspectors are also gonna do funerals, so I don't wanna. They're, right now, they're fine, but as we grow, I don't know, so
Sure.
just making sure.
Okay.
I have a couple of quick comments. The first, if it's a brand new facility, then I think I read in here that they would have to consult with the commission early. Is that right? As far as their plans are concerned?
Well, there was some recommendations about consulting with the commission prior to the start of construction.
Right,
Not
right.
that that's required, but just a recommendation to talk about if this would fall under a significant alteration, then requiring re-inspection.
or if they're doing considerable construction, they finish it all and find out they missed 3 of the large inspection points, then they're gonna spend a lot of money trying to fix those problems.
Right. So I guess one question is, should that be a requirement versus a recommendation? And then as far as the term recommendation at the top that Ms. Mena asked about, I guess is recommendation because we're submitting it to the commission to consider? Because the commission is going to set the standard for inspection of facilities. So that's what we're talking about, right?
So I see, I hear you, Dr. Gilbert. So, because then it could just be a recommendation, not a requirement it could be a recommendation, not a standard. I think that's what you're saying. Like this is.
Well,
what you have to have.
I think what we're being tasked with is recommending rules for the commission to decide on. And if we're recommending the rule, what the commission's deciding on is what are the standards for inspection of facilities, I think.
Maybe Dr. Gilbert, what you're saying is the statement should be, the committee recommends that you require this. So then the commission can look at it and say the recommendation was this should be a required piece and that a rule should be passed upon it.
Well, and I may have been the one that added that statement with the mindset of these are the recommendations by the committee for rules. So, cause I did change a little bit for the stakeholder meeting, just to make clear that these are recommendations by the committee for our stakeholder meeting. So, but that was the context, that they're recommendations for rules.
Or the committee, yes.
Okay, all right.
Let me see. I was gonna say something. So if you go down to, let me see. On the next bullet, 1, 2, 3, 4, on the 5th bullet, a list of approved facilities will be compiled and updated. And Dr. Lee, to your point, that also aligns with your tracking of, for your statistical purposes of what the state has, how many are spoken for, and how many have been released to the colleges, et cetera. So that's a good connection right there. Then the next bullet talks about alterations. So I think we've talked about that, request for inspection within 30 days. And just to your point, it's not a requirement, it's a recommendation. You don't want to spend a lot of money and then realize, yeah, we are not gonna pass because of whatever.
So then the last paragraph and then rolling over into that next page are really just drilling down to be a little more specific on timelines that, both, sides of inspector and those being inspected would follow. Just for transparency, these are same guidance that NATOs would be expected to follow through AAA or AATB. But I don't know specifically if there's any confliction with these within the, the funeral commission side of things. So, I don't know if we want to stick with what's most stringent or if we want to stick with, where the current guidances are. I'm indifferent. It's just that current code did not really have any
Right.
definitions on timelines on when information, would be received back to the facilities and when it's expected to receive, for the commission to have for review.
Yeah, I think for funeral establishments right now, like once if they see anything on site, they give it to them right then and there. And I mean, my guess, it probably depends on, like, if it's a major construction issues, then it may take longer than 90 days. If it's like something minor.
Sure,
Um,
sure.
But I think that could be, if it's going to take longer, then maybe we add something in there that, so I think we talked about this maybe for the application part in the stakeholder meeting, that if it is where it's going to be longer than this time frame, as long as the entity is communicating actively and provides a legitimate basis for why it will go beyond, then it will be acceptable or something like
Yeah,
that.
sure, because as we all know, with city
County
inspections
and-
and
yeah,
county and those
yeah.
types of things, there will be delays. So I don't know, Dr. Ali, if you're wanting to just go through things that are in bold to, ask for
Yeah, I think there's things
clarification.
that are pretty common and not being changed and is pretty general. I don't need personal discussion, but obviously it's your work group. But I think the staff recommendation areas are certainly parts that we want to look at and make sure the stakeholders' input is in alignment with what we're trying to do and that it all works out.
I think the only other thing on that last bullet that we had discussed as a group, Julie, and I think we discussed it in the larger group, is I remember somewhere it said inspection by one or two members of the commission, and we decided on one because when funeral homes are inspected, it's one inspector.
Correct.
So, just for consistency, I think that's what we.
Yeah, correct. With the assumption that our inspectors are competent and comfortable with the task at hand.
Clinton, if you can scooch down to page 2, please, there.
Again, this is kind of just timeline references for, when inspection will happen, when deadlines are expected to be received on plans of correction. And then that highlighted section about abuse of a corpse. Or infractions.
And just so y'all know, if I highlighted something, it was just, because the rule references are gonna change because we're bringing it under the same title as our funeral service, so I'm not as worried about like rule 479.5, because that's gonna all be changed once we move it over to our chapter, so it's gonna be like, I think I'm housing it in chapter 206 or 210 under
Okay.
where ours is, but just so you know, that was the only reason why that was highlighted.
So then on the third page. We've talked about these, I think, in the application process, just what the expectations are on video surveillance, public welfare, accessibility. Make sure that we're clear in definitions and expectations, succinct across the work groups. I don't think that there was any confliction on those, though. We had talked about the unauthorized personnel definitions would be, kind of per facility by policy or definition, depending upon how that facility is organized. For dissection facilities and that stakeholder input, on further definition of clean, well ventilated, that is kind of just generalized description that then will follow all state, federal, regulatory citations that are there in addition to OSHA, infection control practices. And then dependent upon if said facilities are embalming or not, types of chemicals that they're using for cleaning or processing, then, that would really drill down to an inspection checklist or an inspection form. So I don't know how detailed you want to get.
I guess my question, like, do you know, like the particular, like, even if I have the reference for OSHA, then I can pull that and help create like a checklist for our inspectors. I just don't even know where the particular requirements for this kind of thing is. I'm not asking, I mean, like, you don't know off the top of your head and you don't have the bandwidth. I can, like, I just didn't know if y'all might happen to know what the common area is, and I can go from there. But that's more of like, for our inspection team, like, they're not gonna know off the top of their hand if it's clean, well ventilated, well lighted for the purpose that it is required under OSHA or state, and so that's where.
The inspection team will not.
Or our licensing, I mean, you can just grab it and we'll look it up, Google it, but like, it would help if we know if there are current federal state standards that govern this. Like, I know a lot of it is OSHA, but does TCEQ also have something? And that's something I can reach out to.
What about a report for ventilation, a report that gives air exchange readings as an example?
Yeah, well, and then to elaborate on that, if, said expectation is for the designated space to have restricted private access, for security measures, that's going to vary dependent upon the facility. Surfaces being built of materials that can be easily cleaned and disinfected. I can get you some guidance just on general infection control measures.
Or maybe even if it's, kind of what Professor Brennan was talking about, even if there's a particular certificate of compliance that they get from meeting OSHA standards or something that our inspectors know to look for or request or something like that. If that exists, if it doesn't, then we can move forward from there.
Sure.
Quick question real quick. So is the recommendation from the work group that we not require air exchange measurements?
I think we need air exchange measurements.
For dissection facilities specifically that are not working with embalmed or that are not embalming. So I think, some of the emphasis on the guidance is in that italicized statement under dissection facilities about public spaces such as hotels or conference and convention centers are not appropriate unless all of the below standards are met. And while we agree that air exchange is important for the general infection control and health safety of participants, we also felt like that equally important are things such as eye wash stations, hand washing sinks, and being able to clean an environment, before, after, during said dissection lab takes place. So it was less of an emphasis on air exchange, but more of an emphasis on the collective room being utilized for the activity.
And Dr.
Okay,
Gilbert.
so I guess my question is still, are we going to recommend an air exchange limit for facilities that are used for dissection and for skills labs and that sort of thing, or was that only in the case of facilities that are not typically used for those things?
We're happy to accommodate the group. So just to.
It was a long conversation on that part.
Well,
Dr.
yeah,
Gilbert, just to provide.
Sorry, go ahead, Julie.
No, it's okay. So where this has shifted has been the recent information shared that AATB no longer requires air exchange in a number for anatomical facilities.
Right. And so my question to the group would be, why do you think that is? And I'll answer it. It's because the groups that are involved in the AATB, which, by the way, AATB gets paid by don't want that there. So we need to decide for the state of Texas what our requirements are. They're currently set at 7 air exchanges. If that's not what we want, we need to have a reason, not just AATB said so. But I think
The group feels that 7 at a minimum is a fair and just expectation that does not rule out those of us that are currently practicing as such.
right. And I think it's unfortunate that John's not here because he actually has some data from state of Texas autopsy requirements that require a similar or higher air exchange, which would be relevant to groups that are using unembalmed bodies. Because traditionally the argument against, well, we don't use embalmed bodies, therefore we don't need air exchanges measured. There are the autopsy facilities, as I understand from John, have a requirement to have air exchange limits or requirements rather. And so I think that we should probably consider those numbers as we make this decision. That's really all I guess I need to say. But I personally think it should be a measured air exchange requirement for facilities. And I think we should consider for both for dissection facilities that are using embalmed as well as the ones that are using unembalmed bodies. So I guess that's my plea to the group.
Yeah, if I can make a suggestion or comment also regarding that, the state anatomical board in the past has set those criteria and those standards for inspection, that we continue using those standards and criteria along with any additional focus points in those standards. The ventilation, I still believe is important. And that there should be a set number, and this is how you define it, and this is what you need to follow, period. As I've stated before in the past, if this is not your game and this is not what you do on a daily basis, you shouldn't be involved in this world, period. If I don't cremate on a daily basis, I shouldn't once in a year cremate someone because I wouldn't know what the heck I'm doing. So that's my personal opinion. Number two, going from the ventilation, which I think Julie was kind of stating, to the actual ability to clean the place. I know in my skills facility, we don't have dinner there in the middle afterwards in the same area underneath the same OR light that has blood splatter on it. And so the area is designated for dissections, period. Nothing else occurs in there but dissections in full PPE. So if you put a table underneath it later to feed a wedding party, what's in the chandeliers, what's on the ceilings, I don't care what you put down on the ground, can't be cleaned because the facility is being used for two fully different purposes. So for health standards, having blood splatter in a room that then has food being served in it the next hour, a couple hours later, the next evening, to me is an issue that I would bring up and look at very carefully, unless you're going to plastic the entire place, ceiling, walls, floor, and those kind of things. So those to me are even more important than ventilation exchange, but I think ventilation exchange has been defined in the past, and we should keep that standard. It's the health and safety of our people, or radiation through a wall to a family that doesn't know is having dinner on the other side of a fabric wall, and those things that can occur. I say if you're going to do it in a non-traditional facility, fantastic, you still need to meet the standards as any other brick and mortar facility that was built for that purpose.
I agree.
And to that point, thank you for mentioning radiation. You know, if we are wanting to ensure safety and best practices for participants, for staff, for all involved, radiation is absolutely something that would come into play there. Is the use of radiation something that would be disclosed in an application process? Is that something that would be, you know, just talked about under the inspection guidances?
I think it would be good to, like, I think there should be a section in the application process where they disclose if they're going to be using radiation, biochemical, hazardous type. So, yeah, I think that's good.
Mm-hmm. And I can provide some better verbiage on, you know, surfaces that would be like non-porous,
Or even like,
those types of things.
and then also what would it, proper medical terms for the like biohazard chemicals, if there's anything else we should, and I think you did a good job. I think it might have been listed somewhere else, but just in case it's not in there, if you don't mind.
You got it.
Yeah.
Let's see, where are we? So, again, I don't know if others feel the importance as strongly, as eye wash stations, hand wash sinks, all of the other things that are mentioned there. Means of appropriate management of removal of fluids, questions, what would this entail? What would not be acceptable? So through dissection and, educational work, oftentimes suction is required. Otherwise, there's an excess amount of fluid that is then released onto your floor or to other spaces. Not always is it required, however, so I don't know, if it's a when applicable type of statement, and if so, then who gets to determine that? Or if it's as long as you were doing any type of an incision work on something that has bodily fluids, then you will also have this available. I don't know, open to feedback and suggestions there. But that's what that was in reference to.
Is all that required under OSHA?
Bloodborne pathogen, probably, yes.
I was just wondering if it's something that is going to be the standard for our typical day-to-day facilities. Is that something we can just say, the one-time event facilities have to make sure that they would comply with OSHA equivalent standards or whatnot, that the same daily
Sure.
brick and mortar, I don't know.
Yeah.
If that would make it easier or harder on us. I don't know. I was just
Yeah.
asking, open for discussion.
There may
Julie-
be some.
I'm sorry.
That's
No,
my-
I was just thinking then, bullet 1, 2, 3. Bullet 4, 5, and 6, where it's surfaces, access to working, and the means of appropriate management. A lot of those are OSHA, so maybe we can, I don't know, try to bullet those somehow together, I think. What do you think?
Yeah, absolutely.
One comment, if I can make about OSHA, there may be some OSHA standards that may not work for some of our anatomical facilities because it just doesn't apply. So I do caution that definitely look at it. If there's something that applies, we should try to use and mimic. But if there's something that doesn't apply and you force a group to try to use that or say, I'm sorry, you have to meet all OSHA requirements, then you're gonna put them in a position of not being able to do it or too much money needs to be involved to
Right.
fix that problem. So
Yeah,
we need to look at what's applicable is what I would
What if we
say.
said what if we said relevant OSHA requirements?
I think that would be an opportunity to have a little bit of, room to be able to look at things.
And very generic, I think something that like hand wash and sink, eye wash station, I think that is so broad that it,
Well, I think the thing is proximity, Professor Meta. So if I splash things all over my face and I get blood on my face, if I'm in a hotel and I gotta go down the hallway to the public bathrooms to be able to wash my face, first of all, I'm probably gonna not take my PPE off because I'm running to get there. So the idea of the proximity of something like that being in the area. So at a true brick and mortar place that's been built for that, you step outside and they still, lap hallway where the sink is and wash yourself. You're not running through public areas to try to get to a public bathroom. So I think that would be the concept behind.
Sure, because if we are concerned about bloodborne pathogens and exposure, then OSHA standards state that within 15 feet of an exposure, you have eye wash sinks available.
And I'm okay because I know sometimes like when you reference OSHA standards and it changes and we're not aware, so if there's something we like to keep that we just want to put expressly, like instead of OSHA standards, say the 15 foot whatever.
Right.
I mean, if we see that list and just want to highlight and copy in rule verbatim what exactly we want in there, I think that's fine too.
Okay. So then moving on to storage facilities, we agree needing some, the stakeholder input on what constitutes long-term.
Oh, and then we did kind of talk about that. So I think they were talking about it also depends on the type of unembalmed versus embalmed. So if it's unembalmed and not frozen, then I think it is short term. So I guess if it's like used more than 2 days, would that constitute long term?
What are we trying to prove here? Because some of the stuff was written for world body programs that have large storage facilities and they have things that they're holding in tanks and refrigerators and freezers that are locked. But if you're, let's say you're taking this to a surgery center
Mhm.
and they're doing a lab on a Saturday or a convention center or wherever, that to me is more important because these aren't built to do skills labs and gross anatomy labs. So at those types of non-traditional facilities, how are they storing it where it's secure, out of line of sight, not causing any kind of biohazard to anybody that walks by it, right? So that to me goes with the chain of custody. So if a will body program or NATO is providing that body, that they follow those rules that are set by the state of Texas, that these things must be met. If you're an anatomical facility, you're receiving a body and you're keeping it overnight, then you should have a storage facility that's secured and locked, right? Now, the volume, size and all that, I think that gets to be a little very vague in trying to describe that, or long-term or short-term. It shouldn't matter if it's long-term or short-term. What matters is the dignity and respect of the donated body, that if it's there for an hour or if it's there for a year, that it has to be stored in a place that meets all our criteria for dignity and respect and for security and line of sight.
I think they've got that in that first sentence with facilities with the ability to store cadavers should be of sufficient size to manage their respective volume. And maybe we just do something like that about, are the tanks for embalming, is that, I don't know what tanks are, is.
There's gross anatomy tanks, there's embalming tanks, there's all sorts of different types of things, but once everything's done and completed and the preservation process is done, then you store in either dry storage, cold fridge, or frozen.
So the tanks could also be storage places, not just for use.
It could be a
or-
cooler. So a
Okay.
fresh, unbalmed, fresh body that's
Right.
arrived in a cooler to a facility is considered a storage
Okay,
box. But if it's marked correctly and it's out of sight, secure, and those things, that's what I would think would be more important. than
if
the
it's referencing
volume.
storage specifically, maybe we just say storage tanks. And then you could say must be conducive to easing cleaning and, the preservation for the appropriate type of cadavers stored or like consistent with the type of cadavers stored or something, I don't know.
Do we even need to worry about the word tanks?
Y'all tell me.
Storage units.
Well, I know we keep on saying
Storage
tanks, but
areas? I
well,
don't know.
it's just storage,
Mhm.
period, whether it's short-term storage or long-term
Mhm.
storage, right?
There's,
tanks.
I think if we could do storage areas,
Okay.
like, so that we know it's specifically where the cadavers are being stored. And that way that's for your average person and not just those who are in the,
Because when you get into
Industry.
refrigeration and those are more specific to what's being done, right? So if it's
Yeah.
that day that the cadaver arrives and they're doing the lab that day, there's no
Mhm.
refrigeration. If it's kept overnight, you may not need to refrigerate it, it sits in a cooler, but if it's being held long-term, maybe a world body program, then maybe there are standards as to how cool you're supposed to keep it.
and maybe.
Yes, Dr.
I'm
Gilbert?
sorry.
Yeah, so I think then to your point, I think it's also going to determine what state the body's in. If it's unembalmed, then the refrigeration is going to be way more important than if it's an embalmed body. So the ranges, I think we might need to be a little careful with the ranges here, but for an embalmed body, those, they don't necessarily have to be close to frozen. Those are typically they're in our lab for months at a time at 65 degrees. I think the humidity is an important piece of this. If it's an unembalmed body, then the temperature range is way more important in my opinion. So
Is there like a general practice? 'Cause I know that, I think the 34 to 40 degrees, I know that's more for like funeral, service storage, but like for embalm, let's say for both types of embalms, just regular embalmed and unembalmed frozen. Is there an industry practice of what the refrigeration should be at to preserve the unembalmed versus unembalmed frozen?
yeah,
Well,
so
It's 34 to 40.
Just regular,
Uninvolved,
okay.
yes.
yeah, so I think the optimal is for unembalmed is probably what's listed 34 to 40. For an embalmed body, probably in storage would probably be around 50. But once that body's on the floor being used for a dissection course, it's going to be at room temperature, whatever that is for the participants, which is probably, 65 to 70. So hopefully not 70, but point is, I think we need to be clear what we're talking about. If you said that we had to store our bodies at 34 to 40, well, that's not currently what our morgue is at because they're embalmed. It's not necessary.
I think we could also say, really quick, addressing when you're saying what they're at when they're the embalmed or being dissected, maybe we could just clarify, this is what the storage needs to be when the donors are not in use. Do you know for unembalmed frozen, what it may need to be? Does it need to be that same 34 to 40, or if it needs to be?
Well, it's frozen. It's
Okay,
32.
Yeah.
I'm looking at that administrative code, chapter 201. Now I remember why we put number 20, because it says refrigeration of body, maintenance of an unembalmed dead human body at a temperature of 34 to 40 degrees Fahrenheit. I think that's,
So
remember, Julie, that we were, I think
Yeah.
Cody was one bananas looking for that.
Yes,
Okay.
yes. And so I think the assumption is that with the word storage, the intent was when not in use,
Right.
when not in that, educational environment. Now, because that can kind of
Right.
open yourself up
Yeah.
to a whole
And all, yeah,
situation.
that makes sense to me. So I think the only thing we might need to do is clarify that 34 to 40 would be for an unembalmed body.
No problem.
And we may want to come up with a different degrees. For instance, our morgue, I think, is set at 50, if I'm understanding from Jason correctly. And then if it's frozen, to answer your question, Sarah, that would be obviously 32 degrees Fahrenheit or 0 degrees Celsius. I think we ought to be careful requiring frozen to be at a particular level. That's going to be dependent upon what that body's going to be used for. We've frozen bodies at a much colder level, and they're actually, it creates damage to the body where it's not as usable when we do thaw it. And so I don't think we need to do -20 or -80 or anything like that. I think we just need to say frozen, which would indicate below the freezing point.
So I think for my inspector's standpoint, or even enforcement, like if they're looking at whether maybe there was an abusive corpse in the way that the body was stored or something like that, like if there was ever a complaint filed, then they go and inspect, like if they're, devil's in the details. So to help them on that part, is there anywhere, because I know like in one of the stakeholder meetings, they were mentioning how there's industry standards for like transportation that might be good to follow. Is there anywhere else that might have like industry standards for embalmed or unembalmed frozen that we could pull up, just like a range of what might be recommended
I
as
think
good
that
practice?
the organizations that do this are the Will Body programs and the NATOs as a whole. But if the three categories are in use or not in use, and then the not in use is frozen, which is 32 or below. So you're not giving any floor or ceiling, it's 32 or below. And then if they're unembalmed and they're being stored without being used, it needs to be 34 to 40. Then you've covered all your areas. In use, it could be whatever the temperature is in that room, right? If you're storing it and not using it and it's fresh, then it needs to be 34 to 40. If you're storing it and you're freezing it, it needs to be 32 below. So an inspector can come in and say, this is your freezer. Show me the log on your freezer temperatures for last month. And if he or she sees the freezer going up to 50 and coming back down to 30 for a week, then they know there's an infraction, of that rule.
Yeah. So I also agree with that. The other category would be embalmed bodies that may need to be below, I don't know, 60 or 55 degrees. And then when they're in use, they're at whatever the room temperature is. Maybe the other piece is that they need to be stored in a climate controlled area. And then we list those ranges would be, I guess that's obvious, but maybe we ought to state it.
No, I like that. And maybe it's you keep it to a secured climate control area, period. And then for inspection purposes, dependent upon type of facility and type of preservation processes that are applied or not, then there's guidance in that inspection checklist as to what they need to look for.
Yeah, I like that.
Okay.
If you look at Texas Administrative Code 25, I think it says what we're saying. Or it could help us. No human body may be held in any place or be in transit for more than 24 hours after death or pending final disposition, unless maintained within 34 to 40 degrees, or is embalmed by a licensed embalmer in a manner approved by the Texas Funeral Service Commission. So to me, that tells me, or if that body's embalmed, with 1 gallon of formaldehyde for every 50 pounds, because those are the Texas Funeral Service Commission guidelines.
Thank you. That's helpful.
So I think that covers both of what we're trying to say, and that's Texas Administrative Code 25.
You know what rule you're looking at?
What chapter number?
It is chapter 181, rule 181.4.
So I do think we need to be careful in not being too prescriptive in terms of the embalming method or process, because the purpose of embalming is different from funeral service, funeral preparation, I guess.
I agree with you, Dr. Gilbert, that the committee and the commission should be setting rules for anatomical usage of bodies versus funeral services of bodies.
Yeah.
That we should be careful in borrowing, definitely look and refer and help, but there are going to be new standards and rules that I think we should be recommending.
Yeah,
In
so
that
that
case,
just,
I think it's helpful because the temperature range is there, and that's for effectively the time frame of death to any embalming, and seems appropriate to me.
okay. And then, yeah, just to kind of segue into that next section is preparation and embalming areas. And those 4 following bullet points, are specific to, safety and such as 7 air exchanges, type of equipment and materials that are utilized for easy cleaning, embalming formula and wetting solutions. I don't know if that's appropriate terminology or verbiage use still.
I think so.
And then, okay. And then a reference of the occupations code to persons preparing or utilizing the cadaver. I'm assuming that has to do with PPE to be worn when applying such, but I would need to reference that one.
Let me look it up real quick.
And then the next bullet point on search and rescue organizations and forensic science programs. That's something that, to be quite honest, I've not done a whole lot of research on. So I don't know how specific we need to be for these types of opportunities, in the written rule as opposed to when inspecting.
I think they're going to have exemptions, right, as to how they store their bodies, right? And how they're presented, that they will be in soil, that may be covered, they may be sitting out exposed to the elements. So the forensics groups and these research groups that do those things have the exemptions, but it's the security, it's the dignity and respect. If they follow those standards, then I think you're going to meet what the common average person would expect of a place like that.
And I think what we can do is, because I think when I was talking with one of the professors, there's only 2 authorized forensic science in the state of Texas, so I can send them all of what we're walking through, and if they have any concerns or saying this wouldn't be applicable, we can make the appropriate changes.
Okay.
Yeah, and I think the keys here, actually, I don't know if we'll ever get there, but we're interested in seeing about establishing one up here in a different arid climate compared to the other 2 in Texas. But I think the keys here are really the access and security of the facility. I think when you say access is restricted to search organization personnel, I think that may be a little bit too narrow. Maybe forensic field investigators might be considered in that group, but I think we could expand it to say forensics teams or search organization personnel. I don't know what the right term is. Maybe we can get that from San Marcos and Sam Houston, but I think the key would be that it's not viewable from the public. It's kind of off the grid, hidden, secured, whatever. So.
Okay.
Do you want to see if any of them?
I think on that one, none of us were really sure
Can we?
what we were reading.
We're allowed to, I mean, we're allowed to call on anyone, so if you want to just ask if anyone from forensic sciences on the call.
So we're allowed to ask if any of the participants on the phone call are from a forensics search and rescue organization. Do we have anybody?
Oh, is Cody Lepaski on?
Cody is.
Can you add him as a panelist, and you'll need to acknowledge he is now.
Just acknowledging one of our committee members has joined, Cody Lepaski. Cody, are you there on video so we can see you and wave at us real quick, or? There you are, and your video, please, sir. Thank you, sir. I see you. All right. Is there anybody on the participants who is a search and rescue organization or forensic science program in the state of Texas? Not seeing anybody. Okay, then we'll reach out to them and ask them if there's any exemptions that they seem would be appropriate to add to that section that would affect them differently. And Dr. Gilbert, your statement of ours may be indoor or something different. I think there should be a general statement if you're doing forensics and you're doing research of that type, there may be some exemptions on, temperatures, those things, but the same security measures, restrictions, dignity and respect should follow.
Yeah, I think the biggest issue here is that the facility requirements that we're trying to outline don't fit. That's why they have exemptions. And then I think the key here would be to say that the only people that have access are, authorized people to be in there, whether it's a sheriff's department search and rescue canine unit, or whether it's a forensics master's degree student who is becoming a forensics field investigator.
Can that just be put as forensic science programs and authorize individuals from that program? That covers everybody. So it's up to the forensics program again to create the authorized list, not the commission's.
Sure, just like.
Yeah. That's my point. I think we should leave it as the same way that the will body programs are authorizing users.
Right.
Whoever's in charge of that facility is authorizing use.
Correct.
Agree.
Cody, unfortunately, I need your video up. I know you're in the car to be able to comment. Thanks, sir. Appreciate it. Okay, records.
The next would be technical support, needing, some input on. We know that we need to have either a, staffed or contracted, or I assumed staffed, licensed embalmer for that practice to take place. Similarly, we had some lengthy discussion as to either staff or contracted for a funeral director. In current code, it states for oversight of transportation.
Yeah, and I think, so that kind of, well, I don't remember if I raised it in a stakeholder meeting. I know that's kind of been our backdoor questions, because right now, if you're simply removing a decedent from like a hospital and taking them to the funeral home, you're not required to be licensed. Now, if you're directly interacting with family in that process, then it does have to be a licensed licensed funeral director. And this is where I was talking with our general counsel about too. I don't, it may be at the will of the commission. I don't know if we can require there to be a licensed funeral director, since we don't require it for funeral directors. I don't know if it's exceeding our statutory authority. We can make the recommendation. I can do a little bit more legal research on that if that is the will or the recommendation of the committee, but just so y'all know, that is one of the legal things that we were kind of working through on that.
Okay.
Seems like we should be consistent with whatever the status is from the Funeral Services Commission and that. I don't know.
Yeah, we've been trying to.
I wouldn't think that we would want a higher standard. I don't know.
Julie, I think our other question, and I don't see it on here, was we were questioning the word supervision.
Right, because it had that they were supervising the transportation aspect of it.
And so I guess if y'all are wanting to keep it consistent with funeral service, then I would say if it's a decedent is being directly transferred or transported from one authorized entity to another with no involvement by the family or next of kin or the public, that I think it could just be following the same transportation rules. But if it is going to involve a family member, next of kin in the process of the transfer, then you would need a licensed funeral director.
So let me ask you something.
Mhm,
Back to
I'd
the
agree with
final, back to the final disposition.
mhm,
If they have decided on a death certificate that they're donating their body to science,
mhm.
they are now an anatomical tissue. And so licensed embalmers, funeral directors have no say-so over that part.
I would say maybe though, some kind of argument is if part of the donation is that part of the cremains are gonna be returned to the family. And this is where I'm not sure, Chair Tips or Professor Minute, even, President Lepasky, if I don't recall, if, you are returning cremains to a family member and handing that over, is that required to be done by a licensed funeral director or embalmer?
Well, I think we're,
No.
Cody, I think the thing that there's a little bit mixed up is on a first call, when you're making
Yes.
that initial contact with the body versus a transfer. A transfer could be when I pick up the cadaver or the specimen from the willed body program to bring back to the college or university. That's a transfer.
Right.
Yes. Yeah, there's two different types of transportation. One would be that initial first call removal that may or may not involve the family. The other, like you said, Mary, that's just a transfer, and you absolutely do not have to have a license
Yes.
to transfer remains. It's the first call that it can get a little tricky on. And then back to the other question with returning cremated remains, no, that does not have to be a licensee that actually returns those.
So, Dr. Ali, to answer your question, taking the body to the crematory, you don't have to be licensed. That's
Yeah.
a transfer.
So,
Yeah,
but I
absolutely.
think we can keep that consistent. And so maybe just kind of mirroring what President Lepasky was saying about if with the donation, if there is some kind of direct involvement with the family when they're removing it for the donation, if that would constitute a first call that requires a funeral director, then there would need to be a licensed funeral director. But if it's just removing or transferring the decedent from the hospital or nursing home or wherever to the anatomical willed body program or NATO, then a licensed funeral director would not be required.
And so then to kind of loop back around, that would go under disclosure through the application process.
Um,
I'd like to
Sarah,
make
can
a,
you repeat that again?
yeah, but
Can-
hold on. What do you mean disclosure under the application process?
If they have a staff, if there's a funeral director that's on staff, or if there's a funeral director that they are contracted with to provide first call
Oh,
services.
when they're applying, I see what you're saying.
Yeah.
Okay, yes, thank you for clarifying.
Yes.
I'd like to make a comment too, as far as making a removal from a hospital or a facility. I just want the group to be aware that even though we may not require a licensed funeral director to make that initial removal for a willed body from, say, a hospital, there are many hospitals that do require anyone picking up remains to be a licensed funeral director, and that's their in-house requirement.
And I
Because
think,
they'll
I
ask you
think
for your
that's
license
fine.
number.
Yeah, and I
Yeah.
think that's fine, because that's the business practice. I think it's just from a commission side of what's required from our end to be registered or authorized. I don't think we have the statutory
Right.
Authority to do that. But again, if businesses want to have higher standards than what we provide, that's fine.
So question, I agree with the conversation, and I think it's good to maintain consistency where possible. In the folks that are transferring tissue, would it be appropriate and prudent to have that person have some type of letter of authorization to be transporting that tissue? I feel like when we transfer bodies from point A to point B, there's some type of, I guess it's maybe part of the chain of custody that's being used. In other words, if I were to drive to Midland, I'm not a funeral director, But if I was going to take a body part, a heart or something that was going to be used in a cardiac lab, the way we do it is that I have an authorization letter from our will body program director, who's a funeral director, giving me the ability to transport that to another facility. Is that something we should recommend or require, or what?
If I can make a comment on that, Carrie, is that's what I would hope the chain of custody form would be. Is that's also part of the authorization in essence, right? So if I give it to A to take to B, the chain of custody form should be on there. So if they do get pulled over by a police officer and they ask what that is, they can show the chain of custody form authorizing them that they're going from A to B. That would help with that process and keep it organized and clean with transfers.
I'm gonna just interject, because by statute, that's not required for chain of custody. It's just saying who's in it, so I think if you're talking about some separate kind of authorization.
No, I'm just,
That would
it's
need to be
part of the
it.
record keeping, that's all. It's a
Okay.
recommendation. We're not saying that needs to be a rule,
Okay.
but if someone is concerned about that, I think using the chain of custody form would show that there's a purpose behind this movement or transfer,
So we
but it's
did,
not a statute.
right, and we did talk in the stakeholder meeting about, like, maybe some transport company requirements, and, it was mentioned that there are a couple of groups out there that have some best practices. I think the stakeholders were gonna connect me to those so that we could kind of see if there's something we could pull, because I think that might be where you get your authorization, is where we make sure whatever, the way that a decedent is transferred, making sure it's treated with dignity, respect, and all the proper public health safety requirements should meet that, just so that's not like a arm in the back of a car or something like that.
So then moving on to records, I think this is probably some overlap amongst all the areas, but these are already, set requirements that we follow on number of days to file death certificate, other things that we felt needed to be maintained permanently in a donor file or specimen file. And so then I guess on D, actually, we need to remove hydrolyzation.
So that came up during the stakeholder meeting, so, we're gonna pause on that. There were a couple of either statutes or parts of administrative code that I need to research, to see if that is proper or not, and so we'll just put a hold on that for right now.
Okay.
Hey, Sarah.
Yes, sir.
So Jason, Jones, if we want more information about the transportation piece, sorry, Siri is talk to me. Jason has some background on where that transportation documentation piece came from. If we want to hear from him, if you want to talk to him offline, that's fine.
Okay, yeah, that would be great. I tend to have a forgetful memory right now. Can you like shoot a text or email to me with that information? Because that is something I would like to follow up on.
Okay, how about I have him email you with whatever his information is?
Even better. Thank you.
Okay.
Yeah, and then Clint, if you want to scroll to the next page, Cody, just to give you a summary from this morning, we did talk extensively about disposition, final disposition versus physical disposition of remains. This came up in the application process. I do not think that there were any conflicts or any concerns with how you had summarized your recommendations to be requirements.
Yeah, thank you, Cody, for all your help on that. And as Julie said, we did discuss final disposition being different from physical disposition and cremation processes. And then yeah,
Perfect.
also
Thank you.
stuff has been removed. Okay, Cody and Mary and Julie, thank you so much for all your work on that work. That's a lot. Inspection is not easy. I think the other two groups had a little bit easier than you guys. So thank you for all the incredible work and help you guys put in there, sir. Thank you for helping guiding them with the legal issues with those things. Looking at our agenda, we've gone through number 3. Number 4 is discussion of final rule recommendations to provide Texas Funeral Service Commission. So now your goals are, and we got to work on one thing on the work groups. is the work groups will now submit their final bullet points to Sarah, who will then take and convert, like she said, and get it back to us for final rule recommendations to the commission.
Real quick, because I know you talked about wanting to change the work.
Yeah, and that's what,
When you do, we will need to, there needs to be a motion and a vote
yes,
on those.
okay, thank you very much. And that, I'll do that in 6, if that's okay. Okay. Number 5 is discussion of process communication with the commission of committee recommendations, and the process which the committee receives direction from the commission. That's what topics or issues advice is needed. So Sarah and hopefully myself are working with the commission to see what their top priorities are to get it to the committee members to do research and do kind of the same exact thing with work groups to get best practices and recommendations back to the commission so they can look at it and move forward with smart rulemaking and any other decisions they need to make. We have asked as a committee to be on their agenda for their commission meeting. So when they go through a lot of these rules that we're recommending to them, one of us is present to be able to speak publicly and provide feedback. I will be at that meeting. Anybody else is always welcome to come. But we're asking that we put on the agenda as a formal part of it so we can give input. So if any of the commissioners have questions or concerns, they can be addressed directly to a committee representative. And then oh, sorry, Dr. Gilbert, go ahead.
Yeah, I have a question dealing with the out-of-state issue. Do we need to finish the agenda portion first and then let me make my question or plea, or do you want to do it now?
Well, as the out-of-state is part of the distribution and determining where the body needs are is one of our work group topics, we can discuss that. I did bring that up as an aside about what to do with out-of-state transfers that are on hold that the commission is going to approve. So
Why don't you say it in front of everyone?
okay, yeah, so what the discussion is once these rules have been issued forward and the commissioners have an opportunity to look at them and say, okay, this is what the committee has recommended. We've had our opportunity to ask questions. At that point, we will ask if we can have those out-of-state transfers be confirmed through the application process. So the groups that have already applied that are sitting kind of in limbo will have the opportunity at that point to be approved by the commission if they feel that they have all the information they need and they feel comfortable with making that approval at that point at the meeting. I know that's August 27th. I know there are schools that are starting beforehand.
Yes.
But you do have the right to ask for a special commission meeting if there is a particular topic, if I understand by statute.
Well,
that can be requested.
My impression from being in that meeting was that there was some concern about whether or not we could meet the needs in Texas first. Now, I wasn't in the closed door meeting. I don't know what happened. I'm not sure what the issue was, but if the concern were from the commission, as I presume, was that we don't know whether we can meet the needs in Texas, I think through the stakeholder meetings and our meetings today and this one, that's pretty clear that we can. If the commission were given that information, and it would seem like if they had that information and were clear on it, then the decision might have been different. What I would love to see happen is that information be communicated to the commissioners, and we've put a process in place for these out of states to request, and they did everything we asked them to do, and then we said, well, sorry, that's not good enough, or sorry, we don't know. So I just feel like we should be able to find a way forward without getting the entire rules changed, because we created an interim process and now we're not using our interim process. So I just need to maybe make a request that be a consideration, that we ask for a special commission meeting to make decisions on the facilities that had followed our process. And with the commission having the information that we have now, I'd like to think that maybe a different decision would be made. So anyway, I guess I'm formally requesting that be considered.
And I know one, in our discussion, which Dr. Lee kind of mentioned too. So since one of the rule recommendations that we were working on is the in-state needs, that rule presentation will be provided to the commission at their next meeting. And then, most likely, and again, we're trying to finalize the agenda, but one of the recommendations we'll have is that there will be a chance for Dr. Ali to present the historical data and the process and the stakeholder meetings and how we've been able to determine what the in-state need is and how to make sure the in-state need is met in order for the commission to move forward with the interim solution until the rules are implemented.
But you realize that that's not going to meet the needs this year, right?
I can't control the commissioners.
No, but we can provide them information that helps them make a decision. And so I guess I'm just confused that my feeling is the date on the original request for in-state request was, it's listed as Tuesday, July 25th, which I think it was supposed to be June 25th. We didn't have that data, so we couldn't move. We now have clear data. There's almost 700 bodies, it seemed like, that are earmarked and not able to be used. They're all long-term prep. So a logical step forward would be to say we've gathered information we thought the commission would like to know. Based on this information, would the commission consider having an open meeting to make that decision? It'd still be 2 weeks away.
And I think y'all could definitely forward that information along and put it in a recommendation with the historical data collected. I think what we need to clarify on the charts are, the unembalmed versus embalmed, if the schools are able to provide that to show that the needs in Texas for the schools and colleges of the embalmed. To dispose of that. I know we're still trying to figure out, I guess, in the question are the physicians in the anatomical facilities.
Well, I think looking back historically, the whole body programs are the only places they could have requested that anyways beforehand. So they have that historical data. My
No,
suggestion.
I'm not sorry. I'm sorry. I wasn't talking about the historical data for anatomical facilities and physicians. I think I'm talking about how we need to determine that their need is met.
Well, we sent an email asking everybody,
Right,
do you
that's
need anything?
true,
I mean,
that's true.
that's when we did that months ago. So
Yeah,
I would,
that's
I would kind of double up on what Dr. Gilbert's saying is, can we pass that information on to the commission as soon as possible? So they, before their session on the 27th, can make a decision on that one matter smartly to be able to either approve or disapprove.
Yeah, so I think what you'll need to do is, hang on before I just want to make sure we're. I'm not violating. No, give me a second. So what we. I'm looking at our agenda to see how we need to fit this in, so give me 1 second.
I meant to bring it up during the discussion on that specific agenda topic. So my apologies. I think we were going to lunch and I was hungry.
No,
Works.
you're good. I think I'm trying to figure out how we can move forward with that recommendation based on the agenda.
And it has been on previous agendas too.
No, I know, but we're on today's agenda.
No, I understand, but out-of-state transfers are discussed in today's
Oh,
agenda.
no, I know. But we're not presenting it as a rule. It's a presentation of this is why you should move forward with out-of-state applications.
Right, but that's not a rule we're trying to set. We're trying to give data to the commission on something that's not a rule.
So let me ask this, are you wanting the information to come, because if you're wanting the information to be formally from the committee, that's where I'm trying to figure out how we can do that based on today's agenda. If it doesn't have to be formal committee and we kind of put together the information and I provide it, just saying, here's the data that they
Gotcha.
collected.
Right.
I think we can make that work. I just don't think we can make a formal
I
committee
understand.
recommendation.
Well, whatever path you think is
Okay.
smarter, more efficient, let's
So-
take that path.
Okay, so let's do this. Hang on, let me pull up where I don't think I have it printed out. Let me look at the Word doc just real quick to see what any other information I need. 1 second.
I think, Sarah, too, it's, you've had stakeholder meetings and committee
know.
meetings. All that information to you as the executive interim director,
Right,
it's information you could share. So I
right,
think
yeah,
that's
for sure.
valid. And in the stakeholder meetings, what I think I counted was 700 bodies that were embalmed and not able to go anywhere. Is what I remember.
Okay, so what I probably will have to do is because the email that was sent out was for the June meeting, so I will probably have to send out one more email to all authorized entities saying that by a certain date, please let us know if you need anybody. I mean, it could be, I can make it like,
It's close of business today. It had the date of July 25th.
well,
or
but
yesterday.
remember, but that was for the June commission meeting. It's not for the August commission meeting. And so,
Did you send something out for,
but that's why we didn't consider out-of-state applications that were for September, was because we knew we weren't gonna know the needs
Right,
from
but
June to August.
we're talking about doing this quarterly too.
Well, but we haven't adopted
No, I
that.
know, but since it's been asked before, what was the demand? It was extremely low. We're talking about 5 or 10,
Mhm.
right?
I'm not
So
saying that it's,
Right.
we're gonna have an issue.
I just say
It's
you
just
just-
making sure we have to
you
meet
give
our
the historical data,
statutory-
what was asked for a month ago, right? And you can send another email today saying, you know, you have till Tuesday.
Well, I may try
whatever.
to get, yeah, I may, cause regardless, we have to post, if the commissioners are gonna do it, we have to have a 10-day posting requirement for them to have a special meeting. And so what I could probably go ahead and do is like a 7-day, like to all authorized entities, get back in 7 days if there's a need. And, so I'm just let me process, for the. So what I'll probably do is send out an email to all the will body programs asking, just to make sure, what I'll probably do is send out the chart that y'all put together. And then I think, UTSW provided me with the in-state done at the last anatomical board meeting. If not, I'll get together with them to make sure that the schools for the next academic year are covered. And then assuming it is,
Well, we know at the stakeholder meeting, they're all covered because they all stated that they have everybody covered and they've historically covered. So they gave you actuals
no, I
yesterday.
know, but I need actual numbers
Okay.
in writing so I can send that to the.
So if you have that
commissioners.
data and then you send out your requested authorized
Mhm.
entities of requests for cadavers, then that gives you enough information to pass on to them.
Mhm.
And if we're going to send out a request, does it need to specify fixed or embalmed versus unembalmed? Because
Well, and that's what I would like, because I know that's what a lot of the, will body programs were saying is what they have are the embalmed and there's not a need in state for the embalmed, it's for the unembalmed.
And most of them,
So that's the new information I will need to help.
Okay, so-
resolve that.
okay, so to clarify, you're going to need from the will body programs the number of fixed cadavers or embalmed cadavers that are available within the state of Texas and that they've met the in-state university needs that they've been asked for.
Sorry, I'm also just thinking, because I know that the years are all different. I'm not good with thinking on the spot, so give me 1 second. So. Okay, so putting all the rule discussions we discussed aside. The tentative, because I know there's, because a bunch of these out of state, they're asking it for a full year, they're not asking it on a quarterly basis. And so, and in the rule discussions we have had, it's been on giving the projected needs on a quarterly basis. So. For the I guess if the will body programs could give projected needs for in-state academic for the next academic year, because again, that's what most of these out-of-state requests are for, to show that academic needs are met, and then as well as any other requests they've received from physicians or and all these are just the authorized entities, or the authorized anatomical facilities for the. And then
kind of like the chart we had talked about, if we move forward with the rules that we discussed, they're currently.
Do we have to decide this moment?
I would rather have time to think and email what I
That's what
need. Okay.
I'll find, so you don't have to press on it right this moment, try to figure it out.
Because
Let's
that
do
would
that
help me.
smart. Let me know when you're back on.
You might want to test so they can hear us.
Can you guys all hear us? Just wave your hands. Okay, sorry, we had a little audio issue. So here's what we're gonna do to allow Sarah a few minutes to be able to figure this out. We understand what the request from the committee is to be able to release these bodies to the out of state. She just needs to gather data. She'll figure out what data she needs. She'll email the will body programs for the data she needs. She can get that back and then she can formulate something smartly to get to the commission and go from there. So Dr. Gilbert, your request is we're doing everything we can.
Yeah, okay. Well, I appreciate the consideration and Sarah, thanks for the effort here.
Moving on to the last discussion, 6 on appointment of committee members into work groups. I'd like to make a recommendation that we shift our work groups around a tiny bit to 2 people per work group, which will keep us away from any quorums. That way we can have a third person pop in and out. And so on the application process, I know Dr. Gilbert, Bethany, and Dr. Hubbard were on there. Dr. Gilbert, if I can ask you to step off that voluntarily, that will allow for 2 people on that committee, that work group.
Yeah, so you're firing me?
Nope, I'm asking you politely.
I would be glad to step down and let them handle that.
Thank you. On the inspection process, Cody and Mary, I'd like for you guys to stay on there and ask Julie to step down from that, if that's okay voluntarily for me, Julie.
I'll join the fired club with Dr. Gilbert.
And then you 2 that have been fired are now working together. Dr. Gilbert and Julie, you 2 will work together on the distribution of bodies and determination of needs committee. I will come off those, but I will stay on each work group, allowing a little continuity between all the work groups. So I'll be the third person on that work group. Let me ask you this, do I even need to say I'm on the, as a third person, or can I leave it
That was
open?
my
So
question.
I think it would be good because just since it's gonna be, just to make sure there's no walking quorum. I think
Okay,
it's good.
so I'll be the third person on each of those work groups.
And so just so I have it right in my notes, so I've got Dr. Gilbert and Ms.
Julie.
Long on the distribution of needs work group.
Correct.
Dr. Hubbard and
Beth.
Ms. Wright on the application process, and Inspector President Lepaski.
Correct.
Okay. Let's see.
So that's kind of the reassignment. And also with those work groups and work groups, is there anything you guys want to add to some of your work group items? I'd like to add website to everybody to just start thinking about how the websites should look to help out with your application. Am I allowed to do that?
Well, let me just say, we're working in-house on that, and I think I've given us what you want on the website, but it's really gonna be talking to our IT.
Communication between the committee and the IT to align.
So I told the.
Makes zero-
I don't feel that for the record.
That makes zero
I
sense.
told the stakeholders, because there's some body programs, and we were talking about it yesterday. Because the question that did come up of what's going on right now with the website and Anatomical. And so I just told them to keep operating as normal, and we'll let them know once it all changes. But we are trying to keep it the same because it is set out very clearly. And one of them did ask, if we had suggested changes, go ahead and email those changes to us, but I don't think I think there are other issues y'all need to focus on than website design.
So for the recommendation for agenda items for next committee meeting, we'll follow the same format.
Mm-hmm.
So the work groups, discussion of the work groups, we will also finalize and make our full recommendations formally to the commission at the next meeting. Discussion of time and location, we'll send an email out asking everybody what their availability is.
And just so y'all know, because I'm looking at when we have to have all the information to the commissioners by in time, so we're probably gonna be looking at a committee meeting either what week are we on, the 20th? Probably the ideal dates are gonna be 8th, 9th, 12th, or 13th.
Cause that's gonna give me time to draft, but I really need people to send me updates on a rolling basis. So, and I know Dr. Lee mentioned that earlier, but even if it's just like one rule, send it over. Or if it's like one topic, please send it over because I can start working on it. Because also now, the governor's office and lieutenant governor's office has issued a policy letter for the legislative appropriations request. So a lot of my time is gonna have to go towards that. Because we are under a mandated deadline of when we have to have that in by. Until we can get more staff, I've got to be careful with my bandwidth. So,
So
but
I'll,
just so y'all know, those are kind of the heads up dates.
and I'll work with each work group to kind of push on anything that we can get to her early, even if it's in pieces, we'll do that.
Question, so since I'm no longer on the inspection work group, then I give the information that I said that I would share to you.
Yes, since it's shared as a whole committee now, I have all that information. And
Okay.
anybody who's gonna be on that work group that's different will have all that information now, so it's
Oh.
considered public. for the committee.
Last meeting, did y'all have to make a motion and vote on who was gonna be on what work group and approve that?
We need to do that, that's
Okay,
right. So
I just wanted to double check.
I'd like to make a motion that the work groups that have been assigned, Bethany and Dr. Hubbard on application process, Cody and Mary on inspection process, and Julie and Dr. Gilbert on determination of
I
needs
think
and
you- sorry, I
distribution.
think you need to ask someone to make that motion. not
Yes,
me.
so I'd like to ask someone to make that motion. Go
I'll
ahead,
make
Doc.
that motion.
Okay, Dr. Gilbert has made that motion of the work groups being assigned as stated, and Dr.
I'll second.
Dr. Lepowski, Mr. Lepowski have both seconded. So I need a vote of all those in favor of that motion, say aye.
Aye.
All those against, say nay. So the ayes have it, so the motion passes.
Mhm.
Hey,
Look at that. You did it.
almost sound like a government person. Okay, with that, thank you guys for all your hard work. Sarah, thank you for all your hard work. And we will adjourn. Thank you, everybody.
Need a motion?
Safe driving, Cody.
That's it,
To
right?
adjourn?
No.
Sorry
Make a
for my
motion to
tardiness.
adjourn.
Thank you, guys.
I don't think we do that. Thanks, guys.